11. I see 11.
Sir,
Yeah.
we are live now. Good to go, sir.
Right. So good morning, everyone. It's exactly 9 o'clock, and let's start this edition of the Continuum. The webinar today is on strokes, and there are some very interesting presentations. So let's start with the first one. The first is update on treatment of acute ischemic stroke. The presenter is Dr. Arjun Shah from the Grant Medical College, and Dr. Ashok Shirsat is his mentor. Arjun.
Good morning, everyone. Today I'll be going through the treatment of acute ischemic stroke, especially in the casualty setting where we first meet the patient. So the basic dogma of this would be the 3 R's. That is, first recognize that this is a stroke, try to reperfuse, and help the patient to recover. And this recovery can take days, months, and even years. And that is something we have to start from the first time we meet the patient. The outline of management, very simply put, would be to establish reperfusion, some endovascular therapy, hemodynamic management, anti-edema measures to make sure that the comorbidities of the patient are well looked after, and something we tend to neglect, counseling and communication, because this is not just thrombolysis and mechanical thrombectomy. The treatment of stroke is a lot more than that. The principles of acute stroke care would basically fall under these three headings. Firstly, timely recanalization. Secondly, to optimize collateral flow to the ischemic brain. And thirdly, to avoid any secondary brain injury. So recanalization, very simply defined, is the degree of reopening of an artery that was previously blocked. So we need to understand this concept of penumbra, and that is that ischemic tissue is not infarcted. In other words, tissue is often salvageable, and we need to try and salvage this tissue. To make sure that we can preserve the penumbra in our arsenal, we have two important tools, that is RTPA and mechanical thrombectomy. To avoid collateral flow, we can use various things. Firstly, we must avoid hypotension. Hence, aggressive treatment of hypertension is not advised. Another thing some physicians use is head position, low head position. However, this has to be compared with the risk of aspiration. A formal trial was done to this effect and it showed no benefit. So again, it really depends on physician's choice. If there is a cervical internal carotid occlusion, then we must be a little more aggressive with the vasopressors that we use. Avoiding brain injury. So the most important aspect of this would be sugar control. And a SHINE study was done which tried to evaluate sugar control in patients with acute stroke. The population they took was patients of acute stroke. The intervention was strict glycemic control, that is trying to maintain it between 80 to 130. The control was general sugar control, that is trying to maintain the sugars less than 180. And what they found was that trying to control glycemic control very strictly did not show any benefit. In fact, we know that hypoglycemia is a lot worse than hyperglycemia. So it might be appropriate to try and control the sugar, but not waste our energy in trying to control it too strictly, because that might cause hypoglycemia. Patients who have fever with stroke, if we control the fever, there is definitely better outcomes. However, this is not translated to better outcomes on trying to purposefully create hypothermia in the patient. There are some ancillary therapies that we have to offer, like aspiration prevention and DVT prophylaxis, which definitely improve long-term outcomes. So the acute reperfusion treatments that we have, that is recombinant tissue plasminogen activator and mechanical thrombectomy, these have to be meted out quickly and they can be combined. What we must realize is they might lead to reperfusion injury, which most commonly manifests as hemorrhage and edema. And there's a higher chance of this reperfusion injury if the stroke is more severe or is larger. Hence, patient selection is of paramount importance. So the first thing we have is IV thrombolysis, and we use the recombinant tissue plasminogen activator for this, or RTPA. And the agent we use nowadays is alteplase. The indications are very simple now. Any patient, any adult patient with an ischemic stroke who has presented within 4.5 hours after symptom onset. The FDA has kept this limit as just 3 hours. The extension of these indications is these 5 bare necessities. And this is all we really need to go ahead and thrombolize a patient. That is time of onset. When was the patient last known to be normal? And this should be within 4.5 hours. Secondly, we must ask, are there any contraindications, and keep a checklist with us and make sure that there are no contraindications. We'll discuss this later. The clinical examination should be an NIHSS score. This is not a perfect score by any means, but it's the best and most standardized scoring system that we have nowadays. So that should be the clinical evaluation that we do. The sugar and BP is very important, and perhaps the only lab test that we really need. A simple pinprick sugar is also enough to make sure that this isn't a hypoglycemia that is mimicking a stroke. Blood pressure can be easily checked and should be monitored. And the most important test that we have to do is a CT scan, and a plain CT scan suffices to do thrombolysis. The indications are being relaxed more and more to make sure that more patients can get thrombolysis. So, for example, previously advancing age was considered a contraindication. Now this limit has been lifted. Previously, it was considered that mild deficits do not need thrombolysis. However, if these deficits are bothersome, then by all means, we can thrombolize the patient. One thing is clear, that the more we know, perhaps the more we learn, the less we know. And still, despite all these rigid and ostensibly algorithm based management protocols, there is a increased need for individual, quick and nuanced clinical judgment that is required from the physician. For thrombolysis, the number needed to treat, that is functional dependence at 3 months, is 3.6 if thrombolized within the first hour and a half. It goes up to 4.5 within 3 hours, and then about 6 for 3 to 4.5 hours. So the number needed to harm is 40. So these are good numbers. A very easy way to look at these things and to explain to our patients how exactly thrombolysis will help them is by saying that a third of the patients, that is 1 out of every 3 patients we thrombolize, within 3 hours will achieve functional independence at 3 months. So these are good numbers and an easy way to explain to our patients that thrombolysis, the effects of thrombolysis might be evident even 3 months after. So the agent we use is alteplase, presently the only approved agent. The dose is 0.9 milligrams per kg. This is divided as 10% as a bolus and the remainder over 1 hour. The maximum dose we can give is 90 milligrams. Practically speaking, we get 50 milligrams. A vial has 50 milligrams. So if the patient is less than 60 milligrams, we need to order one of them. If more, then we need to order two. We can drip and ship. That is, suppose the patient comes to us in a setup where we do not have a neuro ICU or any means to monitor the patient. It is acceptable to start the alteplase and then ship the patient to a setup that can take care of him and monitor him or her. A reduced dose was attempted, that is 0.6. However, it was shown to be inferior, and although it had a lower risk of intracranial bleeds, it isn't indicated. Tenecteplase is an upcoming agent, and it has numerous advantages over alteplase. It has a longer T half, it has greater fibrin specificity, it is more resistant to plasminogen activator inhibitors. It can be given as a single IV bolus. It is a lot cheaper, almost half the cost, and especially for our patients in setups like JJ who often cannot afford alteplase, tenecteplase might be a very good option for them. And it can also be given if the patient has a concomitant MI. Studies show that it is non-inferior to alteplase, and in fact, patients who then subsequently go on to have a mechanical thrombectomy, in fact, might have better outcomes with tenecteplase. So the contraindications, a lot of these are very obvious. So I'll just discuss the ones that are a little more nuanced. If the patient has an ischemic stroke within the past 3 months, then it is a contraindication to thrombolize the patient. The FDA, however, has removed this contraindication. If we clinically suspect infective endocarditis or aortic dissection, then we must avoid thrombolysis. If the patient has had any recent intracranial or intraspinal surgeries or any major surgeries in the last month, we have to avoid thrombolysis. A history of GI malignancy or a GI bleed in the past 21 days, again, is a contraindication for thrombolysis. If the patient has a systolic blood pressure more than 185 or a diastolic blood pressure more than 110, we must attempt to lower it. However, if all attempts are not fruitful, then we should not thrombolize the patient unless we have achieved blood pressure control. I'll discuss INR NOACs a little later. If the patient has received heparin within the 48 hours, then we must do an APTT. And if the APTT is abnormal, we cannot thrombolize the patient. If the patient has received low molecular weight heparins in the past 24 hours, once again, we have to avoid thrombolysis. And if our plain CT shows a hypodensity more than one third of the area, that means there is a large stroke. It is best to avoid thrombolysis because there is a very high chance of a reperfusion injury, which is a lot worse, often a lot worse than a stroke. The most common adverse effect is a symptomatic intracranial hemorrhage, and this occurs in about 1.9 to 6.4% of the patients based on various studies. As we expect, old age, hyperglycemia, hypertension, and large infarcts are factors that might increase the chances of hemorrhage. An interesting thing is now that we have many other MRI techniques like SWIs, EWIs, we have started detecting micro bleeds in patients, and it is still of contention whether micro bleeds are a contraindication to thrombolysis and whether they even contribute to the risk of hemorrhage later on. So this requires a lot more studies. Suppose there is a sudden worsening of any neurological function during thrombolysis, it is a bleed unless proven otherwise. The first thing we have to do is stop the thrombolysis immediately and get a CT scan of the brain stat. While we're doing this, we need to control the blood pressure and make sure it's between 140 and 160 millimeters of mercury. And we need to give, and once we prove that this is in fact a bleed caused uh, inadvertently by our thrombolysis, then we need to administer cryoprecipitate and antifibrinolytic agents. This has to be dictated by fibrinogen levels, and our target fibrinogen levels would be 115. We start by giving cryoprecipitate. We can give 10 units plus as much more as we require to achieve this target. Fibrinolytic agents include tranexamic acid, commonly known as PAWS, 10 milligrams per kg over 20 minutes. Another option is epsilon amino caproic acid, 5 milligrams IV, and we can add an infusion of 1 gram over an hour after that as well. Another life-threatening complication of alteplase can be orolingual angioedema, and this is especially common in patients who are taking ACE inhibitors like enalapril and less with ACE ARBs like telmisartan and losartan. The treatment is the same as anaphylaxis, antihistaminic agents, ranitidine, and steroids like dexamethasone. Mechanical thrombectomy will be discussed in more detail in the subsequent talks. However, I'll just go about its basics. It is now considered the standard of care for occlusion of the intracranial carotid artery occlusion or an M1 segment MCA thrombosis. So, if we do have a CT angio available easily and we make this diagnosis, then we must know when to refer the patient and for mechanical thrombectomy. The number needed to treat is just 3 to 7, and if we consider reducing the Rankin score by 1 point, it's just 2.6. And this includes patients who are elderly and who have an NIHSS of more than 20, who otherwise might not do very well with IV thrombolysis. The chance of a symptomatic internal hypertension hemorrhage is 4.4%, comparable with IV thrombolysis. And as alluded to earlier, we can combine IV thrombolysis and mechanical thrombectomy as well. So the indications are simple. We can just remember the number 6. So if we have an adult patient who has a good pre-stroke functional status, there is no point in doing mechanical thrombectomy for a patient with severe dementia, for example. So an adult with a good pre-stroke functional status who has proven proximal intracranial occlusion, has an NHSS of more than 6, has come to the casualty and presented to us less than 6 hours from onset of symptoms, and has a CT score 6 or more as per the Alberta stroke program, then we can consider mechanical thrombectomy. Now we can increase this window to 24 hours if perfusions can show a penumbra. That is, if we have diffusion weighted imaging, if we have perfusion scans, then this 6 hours becomes 24 hours. So I'll go on to discuss some special situations for which we encounter in the casualty more and more often nowadays. So the first is wake up strokes and strokes of unknown time of onset. So once again, the upper limit for these unknown strokes is still 24 hours. However, if we have access to perfusion scans and these perfusion scans show that there is still an ischemic penumbra, that means there is some tissue that is still not completely infarcted and can be salvageable, we might want to offer mechanical thrombectomy or IV thrombolysis for these patients. Once again, the 4.5 hours and 6 hours is extended to 24 hours, not more than that. Mechanical thrombectomy in these 24 hours still has a very good number needed to treat of just 2 to 4, comparable with within 6 hours. IV thrombolysis, on the other hand, has weaker evidence. They say that there is some modest benefit with increased symptomatic intracranial hemorrhage risk, and functional outcomes at 3 months might be slightly better. However, the evidence is quite weak. There are various trials to this effect, but none have effectively proven that IV thrombolysis is definitely should be considered in such situations. Another thing that is happening more often is patients taking anticoagulations, and especially novel oral anticoagulations, because these are becoming more affordable and a lot more patients are taking these. If the patient is on warfarin, then we have to do an INR. And if this INR can be done as with the dipstick method in most casualties, so we get the answers quite easily. Otherwise, if the INR is less than 1.7, then we need to thrombolize the patient, and perhaps this low INR might in fact be the cause for the stroke. If the patient is taking NOACs like dabigatran, rivaroxaban, apixaban, we don't have enough data regarding exactly how to measure the efficacy of this at a given point of time, and hence thrombolysis at present is contraindicated. However, if this patient is being considered for mechanical thrombectomy because of a proximal intracranial artery occlusion, then by all means we can go ahead with the mechanical thrombectomy. What we need to understand is there are some reversal agents that are already available and are in research right now at late stages of research. For example, idarucizumab for dabigatran and Andexa for rivaroxaban and apixaban. In fact, idarucizumab reverses the action of dabigatran within 500 seconds. That's within minutes. So if at a point idarucizumab is commercially available, if we have access to it immediately in the casualty, it might mean that we can reverse the effects of dabigatran within minutes, and these patients might soon become eligible for IV thrombolysis. So this is one place to look out for. Another area of contention, controversial area, is minor and rapidly improving deficits. So this, we should be reminded of the basic tenet of medicine, that is primum non nocere, that is first do no harm. A third of patients who are not thrombolized will have a disability after 3 months. Um, so this might be in favor of thrombolizing patients even with minor deficits. However, we must offset this with a chance of a intracranial hemorrhage, which is life-threatening and a lot worse than just a minor stroke. So once again, patient choice is very important. Again, the physician must use his discretion. For example, a patient might have a mild deficit like just a hemianopia, but if this patient is employed as a driver, or if a musician has some slight weakness or a monoparesis, then livelihood is at stake. And by all means, we must try to do all we can to help them recover from this deficit, which might ostensibly seem minor. So once again, nuanced and quick thinking on the part of the physician is absolutely important, especially when we have such powerful therapeutic agents at our disposal. One of the studies showed that patients with NHSS less than 5 do not benefit from thrombolysis. However, once again, patient physician discretion is very important. Posterior circulation strokes, if a patient has a basilar artery thrombosis, then we should consider, or basilar artery occlusion, we should consider IV thrombolysis and mechanical thrombectomy, and they can result in functional independence at 3 months. The issue here is if these patients anyway have a high mortality even without any therapy. So the argument is that we must do whatever we can to help them out, because if we don't do anything, they either ways they have a poor outcome. So hence there is a school of thought that considers it reasonable to extend this therapeutic window beyond 4.5 hours for IV thrombolysis and 24 hours for mechanical thrombectomy. However, there must be no concomitant cerebellar or pontine infarcts, and this extension of therapeutic window is especially more important if this patient has fluctuating deficits. Stroke in pregnancy, some caveats. First of all, we must make sure that this patient does not have posterior reversible encephalopathy syndrome. This is an important stroke mimic, and there might be fluctuations in blood pressure. And if we do thrombolyze these patients, they might have hypertension and a higher chance of bleed. So we must be very careful to make sure that we have diagnosed stroke correctly. We must rule out venous infarcts also, because these are very common in pregnancy. Suppose we have a patient who is pregnant and she comes to us, and then we want to thrombolize and we want to get a CT scan of the head done. So what we must remember is the fetal
Arjun,
exposure.
you have more slides. How many more slides?
So just a bit, 4 or 5 maybe.
Um, okay, quickly.
Yes, sir.
Yeah.
So a CT scan has very less exposure to the fetus, and so by all means we should go ahead with it, because maternal health is of most importance. So there are not enough studies done for thrombolysis, but alteplase does not cross the placenta. So by all means, we should treat these patients as any other patient and thrombolize them. We do not know whether it might complicate recent LSCS or increase the risk of abruptio placenta or PPH. Mechanical thrombectomy, as with the general population. COVID and stroke is another thing that is more common nowadays. However, there is not enough data. We must treat these patients just as we would any other patients, with two caveats. Firstly, we must protect ourselves and assume that any patient who comes to the casualty might have COVID. And secondly, we must make sure that we give proper instructions on post thrombolysis management, because many of these patients will be sent to COVID care centers where they'll be started on heparin very soon. The future is exciting. There might be scope for mobile stroke units, that is, take the thrombolysis to the patient rather than the other way around. And in cities like Bombay, where there's a lot of traffic, this might be something that will really improve our outcomes of our patients. Tenecteplase is going to be the future. It might replace alteplase as the indicated agent. Perfusion scans should hopefully be available everywhere and replace just the plain CT and help us take better decisions for our patients. And a lot of studies are on underway about the vasopressors, counterpulsation, intra-aortic inflation devices, and fine-tuning our management like general anesthesia and local anesthesia for mechanical thrombectomy. And these definitely will improve outcomes for our patients in the future. So while previously there was this nihilism that patients with stroke are destined for death or even worse, disability, there's a lot we can do for them now. And this is an exciting area where still it is the physician's discretion is extremely important. Thank you.
Excellent, Arjun.
Yeah,
Thanks.
I I
So
uh,
Ashok, yeah.
I found this a very interesting chapter. The 2000 and this was written in April 2020, and the same author, Alexander Robinstein from Mayo Clinic, who was the intensive care specialist and stroke specialist there, has written the one in February 2017, Continuum, on treatment management of acute stroke, same topic. What he said was that you read the previous chapter and then I go ahead. So what I told Arjun was, this chapter is written in April 2020. In other words, he must have sent it for publication 6 months earlier, 2019, end of 2019. So what you do is now, what has happened from 2019, end of 2019 till now, 2021, mid 2021, and also into these points. So he found four fascinating points. And what one was very important, that the role of tenecteplase in India, because tenecteplase is going to be used in India more and more because half the price of alteplase. He found a nice chapter on stroke and pregnancy, the Canadian guidelines that is included, and they're available on the web. He's also found reversal agents for dabigatran and rivaroxaban and apixaban, which is also new. And people in Mumbai have used the reversal for dabigatran to treat acute thrombolysis. He's also brought up this point of rapidly improving ischemic stroke and the management. And of course, unfortunately, he's also found a fair amount of data on COVID and stroke. So this is in fact an update on an update of stroke. What you've heard is an update on an update. You probably heard of some of these topics will be probably included in the next continuum somewhere around 2023. So let's see. I'm very, very happy about what he has worked. He's worked very hard on this, that's for sure.
Great.
Thank you, sir.
Thanks.
A
Thanks,
few
Ashok.
comments.
Yes, sir.
If I
Yes,
may.
sir. Please. Please, sir.
One is I thought each speaker will have 25 minutes, and since we have 8, we have extended the time up to 1 p.m. Secondly, I would like to ask Arjun some questions about head position.
Yes, sir.
You see, it seems prudent to keep the head about 20 to 30 degrees above the horizontal. That promotes venous return and will impair the amount of edema.
Yes, sir.
Secondly, the thing about thrombolysis.
So we can't hear you. So you're gone on mute.
Homonymous hemianopia is not a minor deficit.
But according to NIHS, it doesn't give the
Wait,
point.
Ashok, don't interrupt. Let me finish, please.
Okay.
Suppose a person has a minor hemiparesis. abscesses, minor,
Correct. Your point is taken.
which is rapidly improving.
Correct.
Okay. And I'm going to take up this with small vessel disease also in my chapter on small vessel. So these are just two comments that I would like to make on your presentation. Otherwise, I think it was a very comprehensive and very good review of the modern management of acute strokes.
Lovely. I think there is one audience question from Surabhi Garg. If a patient has had a recent LSCS, is it an absolute or a relative contraindication?
How
It's a major.
recent? How recent?
14 to 21 days is what she has put down. So there must be some patient at the moment. Ashok or Arjun?
Generally, a major surgery is considered a contraindication for thrombolysis. However, even in the article which we went through, they've brought up the same topic, that whether a patient was undergone LSCS, whether she should be given thrombolysis or not, is still a controversial issue. And this population is very small, so there's not enough data on it. So again, this is one of those situations, I guess, where the um, physician should use his discretion and decide whether.
Secondly, I think in this situation, please rule out a venous sinus
Venous, absolutely. Yeah.
in which anticoagulation will be indicated.
Yeah.
Yeah. But
just a general comment. There must be so many women who have had LSCS who developed a venous sinus thrombosis and go on heparin. Nothing much. We don't sort of hesitate giving them heparin. Yeah. So it will be case based for sure. Rakesh, comments?
Yeah. Yes, sir. Within 4 weeks, any major abdominal surgery is contraindication. So even if he considers a major abdominal surgery, because the scar is big, it will go more towards contraindications.
But again,
obviously, yes, sir. Yes,
each case based.
Yes. And mechanical thrombectomy is not contraindicated. So if there is a major vessel occlusion, it is preferable to take for a mechanical rather than going for IV.
That's a good point.
Yeah. I think it also depends on the severity of the stroke.
Yes.
Yeah.
Yes.
What is it doing to the patient?
Yeah. How much is the handicap of the patient? Because she's recently delivered a small baby.
Yeah.
And she has to look after the baby.
Yes.
So I think we have to weigh all the pros and cons before we take a decision.
Yeah. I think Vikram, you put up your slides. I have got one question for people who actually do this. What is the most common hesitation that you find from the relatives or the patient when you are in the ER, in the government setting and in the private setting?
Cost.
I suppose cost is one which obviously is there. Let's say in Bombay Hospital, Hinduja Hospital, Jaslok Hospital.
Still cost.
What is the actual barrier that you face?
I think when I explain to them about the risk, they don't like to hear about the risk. I make it very clear that there is a proportion of patients who bleed. And we cannot at this moment of time say 100%. The chances are he may not bleed, but we cannot at this point say 100%. At that point of time, I also say that the bleeding can be minor, it will be quite benign and it will improve. And sometimes the bleeding can be very major. So I make that very clear to them. So they're a little bit of, they said, no, let me fall off my ankle. Or, they just try and buy time. And I tell them that don't buy time because time is brain. I keep telling them that. I have a little problem.
I generally have found that it's too much for them straight on to understand, absorb, and tell us.
The bleeding fact, they don't like to listen to bleeding.
Yeah. And I think, therefore, more people are now aware of the clot buster treatment. Yeah. They know that such a treatment exists. But I think the more they know before the situation arises, better prepared they'll be.
But they're not aware of the bleeding.
Majority are unprepared. Yeah.
In fact,
they have not heard of the bleeding.
many patients in the private setup are asking the doctor or the neurologist, what
Yes,
about clot busters, doctor?
exactly.
Yeah, they are.
Exactly.
But they're not aware of the risk of the
Yes,
clotbusters.
they are aware that such a treatment exists, but they
Correct.
don't know the relativity of what it means.
Yeah, the risk involved, they're not aware.
Correct. Right. So we go on to the next presentation. That's by the Radiology Department of Bombay Hospital. Neuroimaging in acute stroke. Dr. Vikrant will present and Dr. Sunila has monitored. Sunila has also taken special efforts to put in Indian information. So Vikrant and Sunila.
Good morning. Let's begin today's discussion on neuroimaging in acute stroke. So the
Can
time
you
is,
speak a little loudly, please?
yeah, it's not very well audible. The time is of the essence when diagnosing stroke. Imaging can be used by physicians in diagnosing, determining prognosis, and making appropriate treatment decisions in a timely manner. They say time is brain, and that's why imaging must be fast, reliable, and available round the clock. Various imaging modalities include CT scan, MRI, and digital subtraction angiography. CT is the workhorse of acute stroke imaging because of speed and ease of acquisition, ease of availability, lower cost, and relative absence of contraindications when compared to MRI. CT modality includes non-contrast CT, CT angiography, and CT perfusion. As far as the article in the continuum is concerned, we will be limiting our discussion to CT, but I would also like to mention that we also do MRIs in acute stroke imaging. MRI modalities include diffusion weighted imaging, FLAIR, gradient echo imaging, and MR angiography. In fact, diffusion weighted imaging is known as the stroke sequence. In some centers, when CT findings are equivocal, MRI brain screening is done just to take this diffusion weighted sequence to rule out infarct. Let's go on to non-contrast CT. It is the first imaging obtained in patients with stroke for rapid assessment. The it is mostly used to rule out hemorrhagic stroke and also to identify imaging features that may suggest the presence of an ischemic stroke. Ischemic brain lesions are dark, that is hypoattenuated on non-contrast CT when compared to hemorrhages which are bright, hypoattenuated. Here we can see axial non-contrast CT showing infarction in the right cerebral hemisphere in A and hemorrhage with extension in ventricles in B. Role of non-contrast CT in hemorrhage is most common form of hemorrhage is intracerebral hemorrhage. It is classified based on the anatomic location. Intracerebral, which is further classified into lobar and deep, subdural, extradural, subarachnoid, and intraventricular. Volume of hematoma is calculated by this formula where A, B, and C are the longest measurement of hemorrhage diameter in planes perpendicular to each other. Markers of poor prognosis in case of hemorrhage are blend sign, the black hole sign, and the island sign. So here we can see axial non-contrast CT showing the island sign. That is at least 3 separate areas of hemorrhage separate from the main hemorrhage. The blend sign where hemorrhage has hyperdense and hypodense areas. And in B, we are seeing the black hole sign where a hypodense region is surrounded by hyperdense region separate from the adjacent brain parenchyma. So role of non-contrast CT in ischemia. In case of a normal brain, gray matter appears brighter than white matter. When ischemia arises, gray matter becomes edematous and starts to become darker, resulting in blurring and then loss of normal gray-white matter differentiation. Radiologic signs of early ischemic changes are obscuration of lentiform nucleus, the insular ribbon sign, that is loss of gray-white matter differentiation at the insula, and the cortical ribbon sign, that is loss of gray-white matter differentiation at the surface cortex. This is the axial non-contrast CT showing lentiform nucleus obscuration and the insular ribbon sign. There is some cortical ribbon sign also. Extent of ischemia is assessed in the MCA territory by these two methods, the 1/3 MCA rule and the aspect score. In 1/3 MCA rule, if more than 1/3 of MCA vascular territory has early ischemic changes, the benefit of thrombolysis is limited and the risk of post-thrombolysis intracerebral hemorrhage is higher. In case of aspect score, it is a 10-point ordinal scale that measures parenchymal hypoattenuation or loss of gray-white matter differentiation in the brain territory supplied by MCA. Nowadays, aspect score is used more often. It is calculated at these regions. At the basal ganglia level, we assess caudate, internal capsule, lentiform nucleus, and insula, and 3 cortical regions, M1, M2, M3. At the supraganglionic level, that is at the corona radiata level, we assess 3 cortical regions, M4, M5, and M6. This is how we do in reality. For ischemia, 0 score is assigned for each region. If there is no ischemia, that is near normal brain, 1 score is assigned. Total scores are calculated. A low score, that is 0, means severe ischemia, very poor prognosis, and no brain to save. Whereas a score of 10 suggests patient has no early ischemic changes, good prognosis, and potentially with successful recolonization. That more is the better. Now, the subacute changes on CT. Hypoattenuation on CT increases with time with increases severity of ischemia. It is best to compare changes with contralateral normal appearing white matter. Subacute appearing changes are a marker of increased risk of hemorrhage with thrombolysis. Here we can see a mismatch is seen between the diffusion weighted diffusion restriction and flare. And CT scan is showing only early ischemic changes. Here, this is a patient with subacute appearing changes, where there is matched defect. Diffusion restriction is there, corresponding flare hyperintense signal is there, and CT is showing subacute appearing changes, that is hypodensities. Next is the hyperdense artery sign. It represents a thrombus that is rich in RBCs within the intracranial arterial tree on non-contrast CT. It has a high specificity but modest sensitivity. False positive can be seen in raised hematocrit. Conditions can be dehydration, smoking, polycythemia. And false negative can be seen if the thick CT slices are there, or in case of a thrombus that is rich in fibrin. The eye deviation sign is the other useful sign. We have to look for eyes which are deviated toward the suspected cerebral hemisphere. It helps focus attention where to look for. Here we can see deviation of eyes towards the left cerebral hemisphere, hyperdense vessel sign on the left, early ischemic changes in the left M1, M2, and insula, and M6 region. Let's discuss about CT angiography in acute ischemia. We obtain head and neck CT angiography to visualize all extracranial and intracranial arteries supplying the brain. There is some risk of contrast-induced nephropathy because of the use of iodinated contrast agent. Multiphase CT angiography acquires 2 additional head CT angiography images taken approximately 8 and 16 seconds after the first acquisition. Roles of CT angiography in ischemia are to detect thrombi within arteries, to look for extent of the thrombi, to look for collateral status, to look for associated pathologies, and in planning acute endovascular treatment. So let's look at each by one. Presence and location of thrombus in patients with large vessel occlusions, that is internal carotid artery occlusions. They benefit from acute endovascular treatment, but these thrombi are less likely to dissolve with IV thrombolytics when compared to thrombus in more distal arteries. Similarly, in case of a large thrombus burden, there is reduced efficacy of IV thrombolytis, and endovascular treatment takes longer times. Thrombus within the extracranial arteries pose increased risk of recurrent ischemic strokes. Second is the nature of thrombus. The thrombus, which is red blood cell rich, it is more permeable to blood flow IV contrast and therefore to thrombolytics. Residual flow in a thrombus on CT angiography is graded as grade 0, grade 1, and grade 2. Grade 1 and grade 2 residual flow, this kind of thrombi are more likely to dissolve early with IV thrombolysis. In this figure, we can see a grade 0 thrombus, that is, there is no contrast permeation. Here, we can see contrast permeating diffusely through the thrombus, that is grade 1 thrombus. And here, a streak of well-defined contrast is seen within the thrombus, that is the grade 2 thrombus. So these two conditions are favorable for thrombolysis. The third is we assess collateral status on CT angiography. On the 3 time resolved phases of multiplex CT angiography, collaterals are assessed and compared with the normal site for extent of arterial contrast, delay in filling of contrast, and impaired washout of contrast. Here, 3 patients are seen. In patient A, there is delay in phase 1 filling of contrast on the left affected cerebral hemisphere as compared to right. In the same patient in phase 2, there is normal filling, whereas in phase 3, there is delayed washout of contrast as compared to normal side. So this patient can benefit from early revascularization. In patient B, there is normal filling of contrast as compared to normal side. There is normal filling in phase 2 also, but in phase 3, there is delayed washout. This is also a favorable condition for revascularization and reperfusion. In patient C, we can see in all 3 phases on the affected cerebral hemisphere, there is no vessels are seen. So that means the tissue is dead and we cannot reperfuse it. The fourth one is identifying other pathologies on CT angiography, like extracranial diseases, thrombus, plaque, dissection, carotid webs, focal vasculopathy, vasculitis. Here, in imaging of a patient with left hemiparesis after a minor motor vehicle accident, CT angiography shows dissection of ascending aorta, arch of aorta extending to carotids. Right internal carotid artery is not seen at all, where the intracranial arteries are normal and early ischemic changes are seen on the right side. Here we can see a carotid wave on the sagittal reconstruction of a neck CT angiogram. The fifth one is planning neurointervention. CT angiography can be used for assessment of aortic arch and large artery anatomy. It helps in choosing the type of catheter to be used during the procedure. Location and extent of thrombus within the artery helps determine the device type and profile used for mechanical thrombectomy. So the last topic is the CT perfusion. Technique used involves acquiring multiple scans of the brain over time, summating these scans and generating estimates of cerebral blood flow, blood volume, and transit time within the tissue. It can be used in ischemic infarct and salvageable brain. Brain that has a reasonable high probability of being dead even after reperfusion is called ischemic core. Brain that is not functioning but is salvageable after reperfusion is called penumbra. Here in perfusion weighted imaging, we can see left middle cerebral occlusion. Perfusion weighted imaging is demonstrating decreased cerebral blood flow, increased Tmax, and decreased cerebral blood volume. Diffusion weighted images are not shown here, but it was showing a mismatch with diffusion weighted images, and this patient benefited from reperfusion. CT perfusion can also be used in predicting risk of intracerebral hemorrhage after acute stroke treatment by detecting regions of very low blood flow or regions of brain with increased blood-brain barrier permeability. CT perfusion can help predict the brain regions with increased risk of hemorrhage after acute stroke treatment. So 2 patients are shown here. In patient A, area of diffusion restriction is less as compared to area of perfusion defect, and there is left M1 occlusion. So this patient can be benefited from acute endovascular reperfusion, whereas in patient B, area of diffusion restriction is matched with the area of perfusion defect. Even though there is left M1 occlusion, this will not be benefited from acute endovascular treatment. So to summarize, if the perfusion defect is less than the diffusion restriction, there is no role of reperfusion, whereas in case of a mismatch where perfusion deficit is more than the diffusion restriction, early reperfusion will help. My take-home message is time is of the essence when making decisions when treating patients with acute stroke. Given its ease of use, availability, and speed of acquisition, physicians should use CT as the primary imaging tool in these patients. Thank you.
Fantastic, Vikrant. You covered it so nicely and so precisely. I think we'll invite comments from Sunila before we open up the discussion. And are there more slides to show, Vikrant? Are there any other slides that you have?
No, sir.
Okay. Then I think you can stop the slide sharing and Hiral can put on her slides by the time we discuss. So Sunila, please.
Good morning, sir.
Good morning.
Basically, in one slide only, we highlighted that in our kind of setup, we are still using MRI very commonly. In fact, if we don't find very clear-cut evidence of stroke on the plain CT scan, we do proceed with MR as and when it is easily available, especially during so-called routine hours. But even in non-routine hours, we somehow manage. So, but because this article mainly highlighted on the use of CT, we emphasized on that. Another very practical issue in our setup is that our technologists and our infrastructure is not always very conducive for performing CT angio. Though, as we mentioned, as Vikrant has pointed out, that it is indeed the gold standard. So that can be a challenge. And even if we can perform it well, the other important point is that the post-processing is technically, again, very challenging. So we need very experienced technologists round the clock, which is not always feasible. So that can be a problem as well. And I have observed that my personal experience is that I think in spite of all this, we can miss small infarcts on CT, which are very easily picked up on MR. Very, very easily picked up, especially small infarcts in the region of the internal capsule. So early pickup and easy pickup. And like the diffusion weighted sequence is so good that, even if it's only the technologist doing the scan, he or she can tell you that, look, there is an infarct. So it becomes so easy to interpret. Whereas in CT, it is very often a struggle. And in absence of inexperienced people around, which is very practical, I think we should accept that the senior radiologist cannot be there all the time, at least in our kind of setup. So it becomes difficult to detect early stroke on CT. So if and whenever MR is available, I think we should use that. And when we combine with the MR angiogram, I think it is like it serves as a one-stop shop. Very easily, we do pick up, especially on the 3T scanners nowadays, we do pick up occlusions and thrombi quite easily. And we can avoid contrast as well. So this is what I have observed. I think we should all discuss more about this.
Sunila,
Yes, sir.
what you said is very relevant to the major metropolis.
Yes, sir.
But even in the major metropolis, what you're saying is very relevant to
Yes.
tertiary care hospitals.
Yes.
Please remember that nowadays patients are not willing to commute great distances to
Yes,
come
sir.
to tertiary care hospitals.
Yes, sir.
And they like to go into their friendly neighborhood nursing homes or hospitals
Yes, sir.
for treatment. And therefore, as Vikram quite rightly mentioned, the CT scan is the workhorse.
Yes, sir. Sir, but if I may just add, in fact, you will find there are a lot of diagnostic centers, at least in the city of Bombay, who are doing, it's like a package deal. I think we discussed this in one of the CMEs about 2 years ago also. They do a CT scan, they rule out hemorrhage, and if they can't find the infarct, they do a diffusion weighted sequence.
Fine. That is there. Provided the
Yes,
CT
sir.
and the MRI are in the same premises,
Yes, yes, sir. True.
you know,
Yes, yes.
which is not there in many.
No,
Sure.
it is there.
See, don't compare the whole of India with Mumbai.
True. Very true. Yeah.
Please don't compare the whole of India with Mumbai.
Sir, but then the problem is,
Mumbai has
uh,
more MRI scanners than New York. Let me
yes, sir.
be very frank and say so.
Yes, sir. In the private setup.
Yeah, they have more MRIs.
Sir, but then the utility of CT is will be more only if you combine it with a high quality CT angio and perfusion. Now that will not be available.
Correct. I accept all those arguments. What I'm saying is that we are in a rather peculiar situation in the city of Mumbai.
Yes, sir.
We are spoilt by plenty.
Yes, sir.
And it's like this. I'll just give you a very good example. When the CT scans and the MRIs came at JJ Hospital,
Yes, sir.
our resident doctors started doing CT scans, MRIs.
Yes, sir.
If I restricted them from doing CT scans and MRIs for 1 week, they felt totally helpless in this. So I think the basic training should be on CT scans. If the facilities are available, then please go ahead with the MRIs.
Yes, sir.
But otherwise, we are spoiling them with plenty and they are not able to use their clinical judgments.
That's very true, sir.
You're going to do all this for your clinical judgment to train your residents, or are you doing it for the patient? Isn't it? I mean, what you're doing.
Both Asad, both of them are interlinked.
It's absolute nonsense. I think that the
Good
CT
clinical
scanner.
judgment is done to the benefit of the patient.
Yeah, then it is not the benefit of the patient to use an outmoded investigation. You're only really doing it. The MRI will exclude mimics. It will give you a high quality diagnosis immediately. And that is what Sunila is saying. And I think she's absolutely.
MRI is not available in smaller centers.
And the other thing is about the CT. Having had long experience of getting up at night at all times at my elderly age and gazing, squinting at CT scans in the middle of the night, I find that the aspect score is very difficult to handle. And it's obviously not for me. I gave up using this a long time ago, once MRI was available. And I think that it's up to the neurologist in his institution to make sure that he is making some, or she is making some good arrangements to get the MRI done, as urgently as possible. It'll
no argument that MRI is a better modality. There's no argument on that. But I think this package deal of doing a CT and if not a DWI, I think that really suffices to start treating the patient and giving the patient the best of care.
Ashok
aspects, there's a little comment on aspects.
Yeah.
Where is aspects important? It is important. I'll tell you why. If you're really able to use the aspects, and for that you need a clinician who can interpret CT scan. Please remember that. The advantage of being able to use aspects is to jump from a CT to rule out a bleed in an acute neurological deficit and then proceed with endovascular workup. The endovascular workup is going to get more and more important as time goes by. And it's like how we felt that we are never going to be able to thrombolize, and today JJ Hospital is thrombolizing, KM Hospital is thrombolizing. The same is going to happen with endovascular work. In the next 5 years, I predict that endovascular treatment will be as common as we are thrombolizing today. Let's see if I'm right or wrong.
Yeah. I mean, I just wanted to say that it's very nice to know that the CT and the various things that you can do with the CT are improving. And if you don't have an MR, the CT can really be put to good use. But it's finally, there has to be a malleability and a interaction between the clinician and the radiologist. So what are you searching? Like I have an occasional patient where I'm not sure whether there will be an infarct or no. Is it a stroke or is it a stroke mimic?
Yes.
There I'll be a little more comfortable to see the MR.
Sure. Yes, sir.
Whereas if I see a straight stroke and I want to know whether the carotid is occluded and whether Rakesh should immediately be informed, then I'm very happy with the CT. So I think there is a certain relativity of using these tests between the clinician and the radiologist and the tests available in the hospital. Rakesh, you want to say something?
In a very different way,
yeah,
you are exerting your clinical judgment.
Yes, sir. Yes, sir. But that's part and parcel of the whole thing.
That is what I said.
Absolutely. It's the whole thing together for the patient.
Exerting your clinical judgment vis-a-vis the patient.
Correct. Absolutely. Here.
So personally, I feel that if you
want to put up your slides by the time Rakesh makes his comment.
If you have
Rakesh.
the facility, I think use it.
Of course.
Yeah.
There's no question about that. There's no question about that.
Yes, sir.
But please don't compare the situation at Bombay Hospital or Jaslok Hospital or Saifi Hospital with every other hospital in the city of Mumbai.
Yes, sir.
Can I just ask, perfusion scanning is there with CT and MRI both?
Sir, generally perfusion is done with CT. MR perfusion is technically a little more difficult and it's not being used commonly at all. I mean, if given a choice, then I would rather do a CT perfusion rather than an MR perfusion.
Right. Sure. Thank you.
Yes, sir.
As technologies evolve, in certain aspects, Sunila, you're preferring CT to MR.
No, sir, I'm saying as far as perfusion is concerned, between CT perfusion and MR perfusion.
So see, as technologies evolve,
yes, sir.
There'll be many more things on the CT.
Yes. So there is a technique on MR, which is a non-contrast perfusion, which is ASL, arterial spin labeling, where you don't need to inject gadolinium. Now we have realized, sir, over the years that actually gadolinium is worse than CT contrast with borderline renal function. So, because in that acute, in that emergency state, you will not have the creatinine of the patient.
I think let's move on.
Yeah.
Yes, sir.
So thank you very much, Sunila, for
most welcome,
participating and taking special pains for this.
Yes.
And let's move on to the third presentation.
Yes.
Endovascular treatment of acute ischemic stroke. Hiral is going to present and Rakesh is the mentor.
Yes, sir. Good morning, everyone. So now that we have discussed the thrombolysis in acute ischemic stroke and the initial imaging aspects, now we move toward the next therapy, that is the endovascular treatment. Mainly we'll see its indications and the evidence in support which is existing at a moment, and how can we expand the opportunities to use this endovascular treatment in acute stroke. So first of all, why do we need endovascular therapy? So as we discussed earlier, that there are many limitations of IV thrombolysis in some situations where we cannot use thrombolysis, either because of the patient who present late, more than after 4 to 5 hours, or are having either other contraindications for its use, like we just discussed major surgery, recent major surgery. Then those patients are ineligible for thrombolysis. And then there are some patients who do not respond very well to thrombolysis, who are having large vessel occlusion. So their thrombolysis leads to very poor recanalization of these large vessels. So in these patients, we need definitely we need another manner of therapy, that is the endovascular therapy. And this has really led to a kind of paradigm shift in the management of acute stroke, as we are moving from the concept of time window to the tissue window. So now we have so far discussed that time is an essence. So time is definitely an essence. But if our patients are now past the time window, then we should not deprive them of the potential therapies. And that's how the concept of tissue window has now come. So for this concept, we need to define the ischemic penumbra. So penumbra is basically derived from a Latin word, umbra, meaning the central region, which the darkest region, and the penumbra is the peripheral, the edges of the central region, which has the partial illumination, meaning there is a ischemic core in an infarct which has been irreversibly injured, and the surrounding peripheral region is the penumbra, which is ischemic, but it is still viable. Meaning, whenever the cerebral blood flow is reduced mildly, there occurs vasodilatation, compensatory vasodilatation to increase the blood flow into the tissue. That increases the mean transit time of blood, and hence it increases the oxygen extraction fraction. So by increases the oxygen extraction, it maintains the tissue structurally as well as electrically. So that's how we get a zone of benign oligemia in the outermost region, which is a milder reduction of cerebral blood flow. As the blood flow goes on reducing further, the cerebral metabolism rate drops down, and the tissue becomes electrically dysfunctional, though it is structurally intact. And this is the ischemic penumbra, where it is viable, salvageable, and it is the main target of reperfusion therapy. This also shows the evolution of ischemic region. We can see here when the blood flow is normal, this is the viable tissue. As it reduces a little, tissue becomes functionally and electrically impaired. There are biochemical alteration here. We call it penumbra, and when it reduces further, there occurs membrane failure and the necrosis. But even with as the time increases, this penumbra, the cells in the penumbra also start getting necrosed and infarcted. So the survival of brain tissue after vessel occlusion depends mainly if the circulation is restored, either spontaneously or with active intervention, which can be mechanical or chemical thrombolysis. And also it depends importantly on collateral supply, which will be variable from individual to individual. Collaterals are mainly adjuvant chains of vascular pathways that can preserve cerebral perfusion, though not indefinitely. And other factors determining this fate of the ischemic tissue are, apart from collaterals, the susceptibility of tissue to ischemia, ischemic preconditioning, the location of occlusion, and the other factors we saw, hyperglycemia, body temperature, and like. So just to a few things about collaterals. There are mainly three types of collateral. Primary collaterals are the short bypass segments at the circle of Willis, like anterior communicating artery, A1, proximal ACA segment, and posterior communicating artery. These are showing the example, like here is the ACOM, here is the PCOM, which makes communication between the anterior circulation and the posterior circulation. Then the secondary collaterals are the leptomeningeal collaterals, which are diffusely spread over the superficial surface of brain. Then the tertiary collaterals are formed by the distal anastomosis between the major cerebral arteries, anterior, middle, and posterior cerebral arteries, and also the vessels develop with the new angiogenesis. Here, this side shows the communication between the internal carotid and the external carotid circulation with collaterals. Also, there are some anatomic variation in the cerebral vasculature, which also have a bearing on the fate of ischemic tissue. Here we can see the proximal A1 segment is hypoplastic. Here this is an azygos anterior cerebral artery, which is an unpaired single ACA. Here we can see the fetal PCA rising from the ICA, and here we can see the PCOM is hypoplastic. So after a brief discussion on collaterals, now we will see how do we select patients for endovascular therapy. So for this, we need to know two things. One is the clinical status of the patient, and second is the imaging status of the patient. So clinically, we see standard NIHSS score, and imaging wise, we have various options: CT, MR perfusion, as we discussed. So if we discussed about CT, there is aspect scoring, which is a 10-point scale, depending on the anatomical structures which are getting involved at two levels, the ganglionic level and the supraganglionic level. And for each of the area affected, we will subtract 1 point and higher the score, better is the CT image, lesser areas affected. But it has got several limitations as we discussed. So we need better precise therapies, which are MR perfusion and CT perfusion. This has been discussed earlier. We can see here, here on the first image, the left ICA is completely blocked, though the diffusion is showing very small restriction, but the perfusion defect is very large. So this is the clear-cut case of diffusion perfusion mismatch, and patient is a candidate for mechanical thrombectomy. But many times we don't get to do this perfusion therapy. As we discussed, these are time consuming, costly, and many of the technical things are involved in this. So what we do in our setting is we just take MR angio. It hardly takes 5 to 15 minutes, and we calculate diffusion flare mismatch and take the patient for endovascular therapy if indicated. So diffusion flare mismatch is what we are doing here. And also this kind of visual mismatch can be sometimes misleading. So for that we need a better software which are able to do automated perfusion reading. These are called rapid software, and these are being used in many of the trials for endovascular therapy because the visual mismatch can be unreliable. So these rapid software can quantify this mismatch to distinguish the benign oligemia from the critically hypoperfused region and the ischemic core. So they have shown that the trials which used this automated CT perfusion reading, the SWIFT Prime and Extend 1A, had the better, higher rate of better outcomes than the trials which used only the CT aspect scoring for patient selection. But obviously we have to keep in mind here, while using perfusion, the potential time delays caused by the cost, and we should be careful not to super select the patient for endovascular therapy with this. So this we'll see with one example. Like here, the patient comes with an acute stroke with aspect scoring of 6. Here on the CT perfusion, we can see a small ischemic volume and a large perfusion defect. So there is a definite mismatch between the perfusion image. That mismatch ratio is 11.2, and patient is clearly indicated for mechanical thrombectomy. But if we see this patient who has come with aspect scoring of 8, he also has this proximal M1 occlusion, but the ischemic core and the penumbra ratio. Here the mismatch is not very much. Mismatch ratio is only 1.2. So if we stick to the criteria which says that if the ratio of hypoperfused tissue to ischemic core is more than 1.8, then only patient is indicated for mechanical thrombectomy. Then we are very likely that this patient will end up into developing a large MC territory infarct, that too on the left side, which is a dominant side. So here comes the role of clinical judgment, that we have to see patient clinically. If the stroke is disabling, if the symptoms are bothersome, then we have to go for endovascular therapy despite of this minimal mismatch we are getting here. So that's how so that's when also the role of collaterals come in predicting the outcome of such patients with such small mismatch between the ischemic and the penumbra. If the collaterals are good, then they predict the better outcome. This collateral scale is given by the American Society of Neuroradiology, which have graded collaterals as 0, meaning no collaterals. 1 is the slow collaterals to periphery, to only periphery of the ischemic site. 2 is the rapid collaterals to the periphery of ischemic site, and to only a portion of ischemic territory. 3 is the slow but complete collaterals to the ischemic bed, and 4 is the complete and rapid collaterals. So here 3 and 4 collaterals grade will be having a good outcome, other than 0, 1 will be having poor outcome. So there are again various methods for grading this collateral on CT angiography also, but as we discussed, this all can be very time consuming. So rather than waiting to calculate this collateral status and predicting the outcome of patient, we should rely clinically, and simple criteria for this endovascular therapy we should follow here, as if the patient age is more than 18 years and he doesn't have any previous significant disability, that is pre-stroke MRI scale is 0 to 1 with occlusion of major vessel IC or proximal M1, and 2 scores are important: NIHSS more than 6 and aspects more than 6. Then this patient should definitely be considered for endovascular therapy. And this simply translates into, as Rakesh sir always used to say, that if the patient is bad, meaning NIHSS is more than 6, and the image is good, meaning aspects is 6, then it's a definite indication for endovascular therapy. So now this was based on the earlier studies, which included only the patients with aspect scoring aspects scoring of more than 6. So they concluded that lower aspect score is associated with poor outcome. But now there are some recent reports in which they conducted mechanical thrombectomy in patients with aspect scoring less than 6, and even they found the favorable outcome without increasing the risk of ICH. So if we now, next topic is trials. We are going to discuss some trials about the timing of endovascular therapy. So first, there were 6 randomized controlled trials which justified the use of endovascular therapy within first 6 hours. And then the 2 trials came down and diffused, which completely disrupted this time window and prolonged it to up to the 24 hours. So these are the main 6 landmark trials for endovascular therapy in first 6 hours. They used different inclusion criteria for the patients: MR clean and the escape and revasket. They used mainly aspect scoring, whereas Swift Prime and Extend trials, they use DCT perfusion image to better select the patient. Most of them received preceding thrombolysis, and then endovascular thrombectomy was conducted. And from this, Extend and Swift Prime used the 2nd generation better stent retriever system with solitaire flow restoration stent retriever, and they found better recanalization rate and the better outcomes in patients. Median NIHSS in all of this patient was 16, 17, and median aspect score was 9 and 7 here. And all of them had significantly better functional outcome, MRS scoring of 0 to 2 at 19 days. And even better in the trials Extend and Swift Prime because of the use of better selection criteria with CT perfusion, and also because of the use of the 2nd generation devices. So these all trials justify the use of endovascular therapy in first 6 hours. Then there was Hermes collaboration formed, and they did the meta-analysis of this 6 randomized trial and concluded that that endovascular therapy within the first 6 hours is definitely associated with better outcomes at 90 days. And this benefit is seen across all the age groups. Even the more than 80 years patients were included, and those patients who received or didn't receive thrombolysis, they all achieved a similar outcome. This is just to mention the thrombectomy devices, how they have evolved. The first generation were this Mercy mechanical embolus removal device, and then the Penumbra aspiration device. And now after 2012-13, there are the next generation devices have come, mainly Solitaire and Trevo. This is the aspiration system, and this is a stent retriever system. Here is a stent retriever, which is passed over a microcatheter. It is passed distal to the thrombus, and it retrieves the clot along. Now, the goal of thrombectomy is to achieve the reperfusion and not only recanalization. So how do we grade this reperfusion is with this grading modified thrombolysis in the cerebral infarction. So here we can see grade 0. Here the proximal MCA is blocked. Here the proximal MCA is blocked and no flow is going beyond this. In the grade 1, some distal flow we can see without the reperfusion. In grade 2A, we can see that some of the flow is getting, almost half of the artery is getting filled here in the 2A. In 2B, also we can see the flow is incomplete, but it is moving downstream and in this arterial territory. 2C is near complete. Here we can see the brain area is getting perfused better than here. It is getting perfused, but the flow is slow and delayed. And this is grade 3 is the complete reperfusion. The whole of the MCA territory area is getting perfused. So the target of the goal of mechanical thrombectomy is to achieve this TICI grade either 2B or 3. Care during and after the mechanical thrombectomy is usually we prefer conscious sedation over general anesthesia, though the trials have shown mixed data. Some have shown that general anesthesia can lead to better outcomes. Some have shown that it leads to worse outcome. Immediate post-operative morbidity increases, but that is completely individual and depends on the patient's condition, of course. Another important thing is to manage blood pressure. As we know that this ischemic area and the penumbra areas, they all are electrically dysfunctional, and they also have dysregulated automatic regulation of blood pressure. So whenever there are significant blood pressure changes, they get more injured. So we have, and many of these patients, since they have undergone thrombolysis prior to thrombectomy, so they will be having their blood pressure reduced to below 180 and 105 millimeter mercury. And after recanalization, we should target to a normal blood pressure that is less than 140 systolic to avoid reperfusion injury. This is a trial from Mumbai only, in which various hospitals from Mumbai, 137 patients were total enrolled and underwent mechanical thrombectomy. And here, this study was compared with the other landmark study for endovascular therapy within 6 hours. And successful revascularization rate in our study was 92% here, which is significantly better than the other devices and other trials. And the MRI scoring at 90 days was 0 to 2 was achieved in about 60% of the patients. It was significantly beneficial for first 6 hours. Now, after 6 hours, now expanding the time window up to 24 hours, that has been done by these 2 trials, Dawn and Diffuse, which included patients which were ineligible for thrombolysis, meaning past 6 hours, but up to 24 hours with large vessel occlusion, either ICA or proximal MCA. And they had different inclusion criteria for both. They both use CT and MR perfusion based imaging with the rapid software to calculate this exact mismatch between the ischemic penumbra and the infarct. And they found a significant better outcome in the endovascular therapy group. The functional independence was achieved in about 50% of the patient in Dawn and 44% of the patient in Diffuse, and without increasing the risk of symptomatic ICH. So they have clearly expanded the time window up to 24 hours in case of large vessel occlusion. But here also some concerns are being raised about late window paradox, that how these trials of late window have even better outcomes than the early window, because one reason is that the control group here was past 6 hours, so that they didn't even receive the thrombolysis, so that benefit control group was deprived of. That may account for this much difference in the outcome here. And also they included CT perfusion and MR perfusion to refine their patient selection criteria, and their ischemic core volume was very low. And despite of the fact that median time to reperfusion was 11 to 12 hours, and the infarct volume being low, meaning that they all were slow progressors and having good collaterals, which led to slow growth of the infarct size, and hence the better outcome at late window. This is another recent trial published a week or 10 days back in the NEGM journal. So this was our trial where about the anterior circulation. Now next thing is coming in the endovascular therapy for basilar artery occlusion. So till now they have found that the endovascular therapy group and the medical care group in the basilar artery occlusion, they showed non-significant difference in the functional outcome. Here the 44% in the endovascular therapy and 37% in the medical care group at 19 days. So the role is still doubtful in the basal artery occlusion. We need more studies for this posterior circulation. And the next big thing is going beyond Dawn and Diffuse. Can EVT is possible after 24 hours? Then there are some 1 or 2 studies I found which are retrospective only, which included patients who are ineligible for the Dawn and Diffuse, meaning who are either past 24 hours or either who had too large infarct to be included in those criteria, or were having pre-stroke MRI scaling more than 2. They're not included in the Dawn and Diffuse, and they received off-label EVT. And out of them, even 30% received functional independence with symptomatic ICH in 8% of cases. So this again raises a question that do we need even more permissive guidelines for endovascular therapy? And for this selection of patients after 24 hours, we definitely need better measures to select the patients. Thank you. That's it.
Excellent, Hiran. Thank you. It was very clear. So, Rakesh, you want to make your comments?
Yes, sir. First about, as all of us know, the best indication for endovascular treatment is major vessel is occluded, patient is clinically bad, that is NIHS is more than 4, 6, whatever criteria we take, but the deficits are more, and the brain is not showing infarct, whatever modality we use, either CT, MR or rapid software. But obviously MR diffusion gives us enough idea how much infarcted core is there. So if the core is small, patient is bad and major vessel is occluded, that is the ideal candidate for endovascular therapy. So if we choose our patients right, literally we can reduce our number needed to treat to 2 or 3, which is the ideal situation. And one only comment about the posterior circulation. Now, before 2014, all trials were showing that even if we do the endovascular therapy within 6 to 8 hours, all of them failed. They passed after 2014. All trials were positive only because patients were chosen right. That is, large infarct patients were not chosen. Same mistake we are doing in posterior circulation now, because we are trying to extrapolate anterior circulation to posterior circulation, and we are choosing patients blindly. So when we choose a posterior circulation patient, if we choose that the infarct is not large, then obviously same results we can get. In fact, in our study, we found there was no difference between anterior and posterior circulation when we treated with endovascular therapy. So maybe a few years down the line, we'll have some answers.
Yeah. How many posterior circulation do you have at the moment, Rakesh?
Sir, it has crossed 50, sir.
Why don't you publish it?
So because it is not randomized. The trial which was published, the NEJM trial, they could do 300 number with randomization, which is a big thing. All our patients are highly selective patients. So we have had patients where we have intervened after 24 hours also, and they have done well.
So you can only establish the safety.
Yes, sir. Yes.
Rakesh?
Yes.
You mentioned if the infarct size is small, but the patient is bad, you would go in for endovascular management.
Yes, sir.
I think to that, you should add that even if there is no perfusion, infarct mismatch.
Yes, 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 sir. Yes, sir. Because, sir, that's what. If we have clinical and diffusion in our hand, then nothing else is required. Definitely, sir.
So everybody is coming down to clinical.
Yes, sir. Yes, sir. No doubt about that, sir. Sir, these studies are done just to prove objectively. So hardly we do perfusion study in acute clinical setting.
Okay.
You know, this a general question, Rakesh, this ischemic penumbra. You know, it looks so beautiful and picturesque in the way the diagrams are. How is that in life? I mean, in right experiments and stuff. Is it like that, core and periphery? It looks too diagrammatic to me.
Sir, in fact, on DSA, we can really make out that this is the infarcted zone, this is the hyperperfusion zone, and this we will be saving. So, in fact, the guide.
So, is that really core and outside, or is it patchy?
So, it is patchy most of the time.
Yeah. So, this picture is just concept, a concept.
Yes, sir.
You know, when you talk about that, what are the MRI correlates when there's a diffusion-perfusion mismatch against the MRI correlates where there is no mismatch? I think that is what Satish is trying to say.
Yeah.
Can we make out whether there is a diffusion-perfusion mismatch just by looking at the MRIs?
Yeah.
So,
you know,
if the collaterals are good, sometimes we can see, sir. Like even the arteries occluded, distal vessels we will see.
What are the pointers that we should look at?
If M1 is occluded and M1, M2 branches are seen on MRI.
It would have been nice if you had shown some of your DSAs or CT angiograms or MR angiograms.
Maybe even later.
Highlight those points.
Yeah, on the Saturdays, if you wanted to show one of the Saturdays,
yes,
it will be very nice to see.
Sir, in fact, one of the slides is Hiral, just show the last slide, that CT Tiki flow. It shows nicely, sir.
Yeah, let's see.
Just put the Tiki slide.
Rakesh, can you point out on this to us? See, but this is on a DSA. This is on a DSA, no?
Yes, sir. DSA, DSA.
No, we are asking for MRI.
All right.
Okay, sir. I don't have.
That's CT.
NGO, I don't have.
Maybe on a Saturday, if
Yes.
you can show us. Yeah.
Yes.
Yeah.
I mean, you won't be 100% right in every case, but at least probability
Correct.
is likely to be a mismatch or this is likely to be a match.
Yeah.
Yes.
Definitely. Sir.
Okay. Right.
So great. So any other questions, comments before we move on? We have one.
Sir, if I can add something.
Yes, please, Sunila.
Sir, as I said that MR perfusion is not being done commonly. In fact, it's very, very rare that we do an MR perfusion for ischemic stroke, but we do diffusion. So one of the ways of making out the mismatch on MR is the mismatch between flare and diffusion, as actually Vikrant had already pointed out in one of his slides. So if we see a larger area of a smaller area of diffusion restriction and we don't see anything on flare, then there is a mismatch.
Sunila, isn't that for wake-up strokes? Where flare will come positive only after about 4 hours?
So basically subacute.
That was to make out between wake-up strokes. Okay, you see something on a diffusion and you don't see anything on a flare, then you can take the patient up for thrombolysis because flare will become positive only after 4 hours.
So sir, basically that just tells you that this is likely to be acute and not subacute.
No, we are talking about the ischemic penumbra.
Yes, sir.
Features of the ischemic penumbra on the MRI, which may help us, okay, yes, we should do a diffusion scan to see whether there's a mismatch or a match.
Sir, another thing which I can tell you is that it's mentioned in our radiology literature and even I have observed this, is that actually, this diffusion is also not 100% foolproof. It's not that the area of restricted diffusion is always the ischemic core, because it is a very dynamic process. It can keep on changing even with spontaneous recanalization. You understood what I'm trying to say, Rakesh?
Yes, ma'am. Now we have studies where exactly 8% is the figure which is coming. So 8% of the diffusion restricted lesions can have reversal.
Exactly. That is what I wanted to highlight. Yeah.
Therefore, that is where the benefit of the doubt.
Yes.
So you always give the patient the benefit of the doubt. When in doubt, go ahead and do it.
Yes.
Fine. Thank you.
If I may add just one note that
yes, please, sir. Yeah.
A neurosurgeon who first called this area the ischemic penumbra was Professor Lindsay Simon at Queen Square, because his unit, his research unit, was doing more work on ischemic lesions in relation to the spasm in subarachnoid hemorrhage than almost anyone at that time. Professor Lindsay Simon coined the term ischemic penumbra. It's now increasingly forgotten. Thank you.
Nice to know. Yeah.
Yes, sir.
Yeah. So I think we move on to the next talk now. That will be delivered by Dr. Katrak himself, and the topic is cerebral small vessel disease. Rohit, please give slide sharing rights to Dr. Katrak.
Yeah, I've got it.
Sure, sir.
Yeah.
Fine. Good morning, everybody. Now, I'm going to talk on cerebral small vessel disease, and the chapter is written by the section editor, Natalia Roost, together with her colleague Mike Atherton, and I'm only basically going to review this chapter. On the title slide, I have shown you two HNE preparations, which are the pathological changes seen in hypertensive small vessel disease. On the image on the left-hand side, you see that the walls of the vessel are markedly thick, whereas the lumen is rather small. And on the right-hand side, you see a small vessel within a sulcal space with a microaneurysm. Okay. Now, please keep these images in mind when we are dealing with the pathology. Now, what is cerebral small vessel disease? It is actually a multitude of clinical and neuroimaging manifestations which are due to focal or diffusely diseased microvasculature. Now, what do I mean by microvasculature? It is arterioles, capillaries, or venules which are less than 1 millimeter in size. And these are responsible for about 25% of strokes and contribute to about 45% of dementias. The main risk factor for small vessel disease is age. As age advances, small vessel vascular disease increases. The other risk factors are the common risk factors for any stroke, like hypertension, diabetes, chronic kidney disease, tobacco abuse, hyperhomocystinemia, and in this case, certain genetic conditions. Now, the vascular tree of the brain differs from the vascular tree of any other organ because it is embedded in the parenchyma to form what is known as a neurovascular unit. This neurovascular unit composes of neurons, astrocytes, endothelial cells, pericytes, and smooth muscle cells. And it regulates the entry of substances and pathogens from the blood to the parenchyma, namely the blood-brain barrier. This is coupled with another function that as neural activity increases, the neurovascular unit increases the cerebral blood flow so that more oxygen and nutrients go into the neurons. The third function of the neurovascular unit is removal of metabolic byproducts like protein and heat, which are rather deleterious to the normal functioning of the neurons. Now, what is the pathology? I think in the early 60s to 70s, C. Miller-Fisher described the hypertension-related microangiopathies. And what he described was lipohyalinosis. That means the vessel wall is more diseased and therefore the vessel wall to the lumen ratio increases. And that was the slide that I showed you on the left-hand side of the picture. He also described arterial disorganization and microaneurysms, the picture on the right-hand side. Now, what happens is there's an increased media to lumen ratio in hypertension. And therefore, there's a discrete decrease of the cerebral blood flow, hypoxia, blood-brain barrier leakage, inflammation, edema, and oligodendrocyte dysfunction. This oligodendrocyte dysfunction results in white matter hyperintense lesions. Okay. And if the media expands quite a lot and the lumen is narrowed until it gets blocked, it results in lacunar infarcts or microinfarcts. The second pathology there is that of cerebral amyloid deposition in the vessel wall, a condition known as cerebral amyloid angiopathy. The pathogenesis of cerebral amyloid angiopathy differs from other types of small vessel disease in its anatomical location and mechanisms. The location tends to involve small or medium cortical as well as leptomeningeal arterioles. A beta or amyloid is deposited in the walls of blood vessels, particularly in the perivascular basement membrane. And this has implications particularly in the hemorrhagic subtypes of cerebral small vessel disease. Now, I'm showing you some of the pictures. This is an article by C. Miller Fisher called The Arterial Lesions Underlying Lacunes, which was published in 1969. And I must give you a background that he and his technicians would take serial cuts, let's say of the brain at the level of the internal capsule. And they would take 300 to 400 serial cuts going from anterior to posterior. And they would look at each cut under the microscope and thereby build a 3D image which he would draw. And this is one image that he's drawn in that article. And he says diagram of the pons showing relation of a lacune to vascular lesions described in figure 2. And there's a histological figure 2, which I cannot show you because I have only a Xerox copy of this. But it shows you so well how the man worked diligently. Segmental occlusion and the further flow is blocked, forming a lacune. And on the right-hand side, he demonstrated how a microaneurysm will block the blood vessel, producing a lacune in the subcortical white matter. This is a beautiful demonstration of how diligently this person worked. Now, these are the various pathological characteristics of CNS small vessel disease. And as you can see, it can result from hypertension, top right-hand corner, coming down, cerebral amyloid angiopathy. You can have a genetic form of cerebral amyloid angiopathy. There are other genetic forms of small vessels disease like CADASIL, etc. You can get small vessel disease because of autoimmune mediated vasculitis, or you can get it because of infections like schistosomiasis producing cerebral small vessel disease vasculitis. But please remember that in India, we must not forget cerebral malaria as a cause of cerebral small vessel disease. And this is a pathological specimen given to me by Dr. Darab Dastu, which shows hundreds of cerebral microbleeds in the subcortical and cortical matter because of blockage of the small vessels due to cerebral malaria. Now, what is the epidemiology? As I mentioned, age is the biggest which increases the prevalence of small vessel vascular disease. Okay, and if you take people related aged 50 years, it is only 5%. And if you take aged 90 years, it is nearly 100%. Cerebral microbleeds occur in about 6.5% in the 45 to 50 age group, whereas it can jump to 36% in the 80 to 89 age group. The second most important factor is hypertension. With a BP, in this chapter, they say hypertension is a BP more than 140/90. The other risk factors are those which are common to other forms of stroke, like smoking, diabetes, OSA, chronic kidney disease, and branch atheromatous disease in the cerebrovascular tree. Dyslipidemia, I have put a little question mark there because dyslipidemia is a robust risk factor for large vessel cerebral vascular disease. And these patients are invariably kept on statins. So the effect of statins or dyslipidemia in small vessel disease is not entirely clear. Then, of course, there are genetic factors like CADASIL, MELAS, Fabry's disease, and a condition known as RVCL, which is retinal vasculopathy with cerebral leukoencephalopathy. And of course, please don't forget infections in India. Particularly at present in the COVID era, we must not forget fungi, namely the black fungus, that is mucormycosis and aspergillus, and the white fungus, which is uh, alba.
Candida albicans.
Candida alba. Now, although C. Miller-Fisher described the pathological changes in hypertensive small vessel disease, the definition of cerebral small vessel disease nowadays in the modern era is molded by the MRI, which has characterized them practically into a cerebral small vessel spectrum disorders. And these spectrum disorders are acute lacunar infarcts, chronic infarcts, white matter lesions, and a modern entity known as enlarged perivascular spaces, cerebral microbleeds, intracerebral hemorrhage, cortical microinfarcts, and cortical superficial siderosis. This is the spectrum of MRI imaging in small vessel disease. However, there are advanced neuroimaging techniques nowadays which will give a better definition of small vessel disease, and that is vessel wall imaging, which is an emerging technique which helps to diagnose various types of small vessel disease better than studying just the luminal image. Then you have diffuser tensor imaging and perfusion imaging, which may detect microscopic damage better than conventional MRI. Then you have functional MRI and bold imaging, that is brain oxygen level dependent, which will show you subclinical damage. And I think the main thing that is coming more and more into practice is the 7 Tesla MRI, which aids in vessel wall imaging as well as detecting microinfarcts. And the last is T1 weighted magnetization prepared rapid gradient echo for detecting enlarged perivascular spaces. Okay, so I think MRI is an evolving thing which will better define small vessel with all these future advanced techniques. Now coming to acute and chronic lacunar infarcts. As you all know, they are hyperintense on DWI and hypointense on ADC. The acute infarcts, the modern terminology is RSSI, which stands for recent small subcortical infarcts. And this terminology has replaced the historical terminology of lacunes because all these infarcts do not cavitate. When we say recent, we mean last few weeks. Okay, they have a predilection in the territories of perforating small end vessels. That is like the lenticulostriate arteries, the thalamostriate arteries, the pontine perforators, and produce infarcts in the basal ganglia, thalamus, internal capsule, and pons. And if you look at all the lacunar syndromes, you will find infarcts localized to these areas. Okay. The chronic infarcts are basically those infarcts which occur in non-eloquent areas, and therefore they are silent infarcts. And they are detected essentially on the MRIs. And they may be between 3 to 15 millimeters in the maximum diameter. With a central CSF density, if they have, it's called as a lacune, which means nothing but a lake. Now, the top two pictures are taken from Continuum, and you can see on the A, you can see a DWI showing an acute small infarct in the right lentiform nucleus. And on the left side, on the flare images, you can still see it. But in addition to that, you can still see a lot of white matter hyperintense lesion forming caps around the lateral ventricles. On the bottom are two of images from my patient who was hypertensive male, 69 years, and this was done in April 2000. And you can see two lacunar infarcts. The one on the right looks like a slit, and the one on the left looks literally like a lake, lacune. Okay. On the T2 weighted images, there's a slight amount of blooming, and therefore they look bigger. Now, white matter lesions are also called by Hutchinsky as leukoariosis, which means rarefication of the white matter. And this is a validated risk factor or a biomarker for acute ischemic strokes, intracerebral hemorrhages, and also for vascular cognitive decline and mortality. Okay. It is also responsible for the functional disability in elderly and in stroke patients, and contributes to impaired stroke recovery. The locations of these lesions are usually periventricular or subcortical. They are periventricular because they occur in the arterial border zone areas, where there is a certain amount of ischemia, hypoxia, and oligodendrocyte damage. And in the subcortical areas, these pathological changes occur in the territory of end arterioles, which are susceptible to the effects of chronic hypertension. The risk factors, as I've already mentioned, are age, hypertension, smoking, diabetes mellitus, etc. Now again, the pictures, the column on the left is from the Continuum where you can see it, and the column on the right is from my patients. The top picture is that of a 73-year-old female patient who was hypertensive and had cognitive decline. But the important part is to look at the bottom image, which is that of a patient who had hypertension, which was uncontrolled. And he's only 50 years old, and you can see the extent of cerebral and cerebellar atrophy with white matter hyperintense lesions surrounding the lateral ventricles with ventriculomegaly. Now we come to the hemorrhagic subtypes. And these can produce acute intracerebral hemorrhages. They can also produce subclinical hemorrhages. They can produce cerebral microbleeds, cortical subarachnoid hemorrhage, and superficial siderosis. The main pathologies are two: cerebral amyloid angiopathy and hypertension. Cerebral amyloid angiopathy produces amyloid deposits into the vessel wall. Therefore, there is loss of integrity of the vessel wall and bleeding events. Cerebral microbleeds occur in about 6% of aged patients, but that proportion jumps to 30% of acute ischemic strokes and nearly 60% of acute ischemic acute intracerebral hemorrhages. The other major factor is also hypertension. And between these two conditions, the location of these hemorrhagic lesions differ. In cerebral amyloid angiopathy, these hemorrhagic lesions are at the gray-white junction, and for some unknown reason, they are more in the posterior part of the lobes, in the parieto-occipital area and posterior temporal area. Whereas hypertension, the hemorrhagic strokes occur in the basal ganglia, in the thalamus, in the brainstem, and in the cerebellum. 4 locations which we know are classical sites for hypertensive intracerebral hemorrhages. Now again here, this is taken from the continuum, where you can see that there is a hemorrhage and there's superficial siderosis. Sorry. And this is taken from continuum, which shows cerebral microbleeds. This is another image taken from an article which shows you white matter hyperintense lesion as well as cerebral microbleeds. And the last image is that of one of my patients with a subarachnoid hemorrhage, multiple cerebral microbleeds, as well as little amount of superficial siderosis. Now, there is one form of hemorrhagic subtype, which is called as cerebral amyloid angiopathy related inflammation. These patients present with a subacute or acute to subacute onset of headache, seizures, focal deficits, or cognitive decline. And I'd like you to see the radiology of one of my patients. This is the CT scan of the patient showing you a parasagittal bleed on the right-hand side. This is the MRI which shows the same lesion here together with white matter hyperintense lesions. But when we did the SWI imaging, you can see that lesion which shows a little bigger size because of blooming, but multiple microbleeds. And this patient had microbleeds scattered all over his brain. At that stage, I did not recognize, this is in the year, I think 2008, yeah, 2008 if I remember right. I was not aware of this entity. And I would like to stress that one must be aware of this entity because there's a possibility of treating these patients with steroids to reduce the inflammatory and reduce the progression of the disease. So I wish I had known about this at that stage because I think the patient is lost to follow up very likely because he's perished. Then a newer entity is this enlarged perivascular spaces. Now modern thinking is that this perivascular space serves the function of removal of toxic solutes, very much like the lymphatics that we talk about in removing amyloid, and it facilitates immunological processes. With the advent of the 70 MRIs, microinfarcts as small as 0.2 to 2.9 millimeter lesions can be detected. And they are due to blockage of the terminal perforators. And of course, cerebral atrophy, all of you know the reasons for that. Now, this is the left image and the center image is from the continuum. The red arrow points out to enlarged perivascular spaces in the basal ganglia. The blue arrow points out to enlarged perivascular spaces taken along a longitudinal length. And the last image on the right is from one of my patients who was a female aged 67 with some cognitive decline. And as you can see, that there is a certain amount of cortical atrophy which is disproportionate to the age of 67. However, this MRI, they mention about normal enlarged Workhoff-Robin spaces. And if I was aware of this entity, I might have said they were responsible also for the cognitive decline of this patient. And you can look at all the enlarged spaces all over the cortex. Now, this is a microinfarct. This is taken from the Continuum with a 7 Tesla MRI, which can show a very tiny infarct there. And this is brain atrophy from 2 of my patients, which I've already shown. Now we come to the clinical syndromes, the last 5 minutes. Cognitive decline, strokes, neuropsychiatric, urinary dysfunction, and gait. I will rapidly go through all this basically because I think all of you are aware of these conditions. The most common cause of vascular dementia is small vessel disease. The risk factors I have already mentioned. What really goes first is executive function, followed by procedural speed, processing speed, attention, and then memory. There's an increased risk of anxiety, depression, apathy, and sleep disorders. And one must remember that between cerebral amyloid angiopathy and Alzheimer's disease, there's a bidirectional relationship. If you look at the pathology of cerebral small vessel disease and Alzheimer's disease, there is a more than 50% overlap in the pathologies. I've already mentioned about lacunar strokes, that there are more than 20 syndromes that are described, but 4 of them are classical. And these strokes, acute strokes, are in the eloquent areas. Please remember there will be acute strokes in the non-eloquent areas, which may remain silent and are detected only on the MRI. So small vessel disease is also responsible for lobar hemorrhages, which are due to cerebral amyloid angiopathy, and non-lobar hemorrhages, which I mentioned the sites, which is due to hypertension with microaneurysms. One point to remember is that if you have cerebral microbleeds in the thalamus in a patient who's had a stroke, very likely in the post-stroke period recovery, these patients are likely to get emotional lability. So please keep that fact in mind. Now, these are the classical syndromes. They're given in the continuum. But what I'd like to stress is that the positive predictive value on imaging overall is 87%. But if you have pure hemisensory lacunar syndrome, it is 100%, and ataxic hemiparesis, if it occurs anywhere in the frontopontocerebellar fiber tracts, it is nearly 95%. So a clinical syndrome, you can predict what the MRI picture is likely to be. Urinary function dysfunction is nocturia, frequency, urgency, incontinence, and that is essentially because of lack of frontal lobe inhibition of the periaqueductal gray and the pontine micturition centers. And the gait dysfunction resembles Parkinsonian gait, except that these patients tend to have a slightly wide base gait, and they will have white matter hyperintense lesions in the internal capsule, centrum semi-ovale, frontal lobe, and the genu of the corpus callosum. Therapy, all of you are aware of all these therapies: reduce BP, statins. Now, aspirin can avoid recurrence in recent small subcortical infarcts. But dual antiplatelet therapy is also beneficial, but in the first 21 days, if you give it for a longer period, you are increasing the chances of hemorrhagic complications. Similarly, with thrombolysis, it can help in recent small subcortical strokes, but please look at the MRI carefully. for cortical cerebral microbleeds or extensive white matter hyperintense lesion, as it will increase the risk of intracerebral hemorrhages by 50%. Various other types of treatments have been tried. And lastly, you can get lifestyle interventions like stop smoking, aerobic exercise, Mediterranean diet, etc. But I'd like to, this is my last slide, and I'd like to spend a little time on it, if I may. Antiplatelet drugs and anticoagulant therapies are generally avoided in cerebral amyloid angiopathy for obvious reasons. However, there will be cases of cerebral amyloid angiopathy with non-valvular atrial fibrillation, in which there are very few clinical trials. And those clinical trials have excluded prior intracerebral hemorrhages. But what about microbleeds, superficial siderosis, and subarachnoid hemorrhage? And there is a CHROMIS-2 study which was published in Lancet Neurology 2018, in which they took TIAs minus strokes with non-valvular atrial fibrillation. And there were three basic findings: that cerebral microbleeds increase the risk of intracerebral hemorrhage. Symptomatic intracerebral hemorrhage was more in diabetics and with vitamin A antagonist. And the absolute rate of recurrent acute ischemic stroke was definitely more than the absolute rate for recurrent intracerebral hemorrhage. Therefore, the main question is, when does the risk of intracerebral hemorrhage outweigh the benefits of anticoagulation therapy for ischemic stroke prevention? That question is not answered by the article, and each individual physician must take his call on an individual patient basis. Thank you.
Thank you very much, sir. It was such a fantastic review. I think a couple of questions for Dr. Katrak we can take.
Yeah.
I have one query. You know, in my clinical practice, I see small vessel disease as a part of generalized cerebral vascular disease. Large vessels, medium vessels, small vessels. There are comparatively fewer patients in whom the mechanisms are non-atherosclerotic and different, and the small vessels are affected more. So when in a chapter like this, when they say small vessel disease, what is small vessel disease to them? Is it any small vessel disease? Because I would think that 70–80% of the small vessel disease is part of cerebrovascular disease. And in that sense, it's not separate disease. So how would you look at it?
See, I think there are certain peculiar neuroimaging and clinical syndromes. If I may take the example of the lacunar infarcts or recent small subcortical infarcts. This chapter is concentrating on the most distal part of the vasculature, which is the small arterioles less than 1 millimeter, the capillaries, and even the venules.
Yeah. So my point is that, yeah.
It does not occur. If you look at the risk factors, it cannot occur in isolation of some amount of atherosclerotic disorder.
Correct.
You know.
So so then when you come down to the crux of it, why are we separating it?
See, because there are some people who get minor strokes and they go undetected. And then when you look at them for cognitive decline, you find that there's extensive white matter hyperintense lesions.
Yes.
Okay. And there are cerebral microbleeds, or as I pointed out in one of my patients with cognitive decline, there was enlarged periventricular spaces.
Yeah.
Secondly, with the advent of the gradient echo and the SWI images, we are picking up many more microcerebral bleeds than what we were picking up earlier. And if you remember the last neurology update by Dr. Singhal, there was a lady from France who talked about cerebral microbleeds, and a large percentage of those patients went into dementia. So I think if you have a large cortical infarct, large in a big area, you can get an acute dementia. But you can also get a dementia with small vessel vascular disease in which there has been no history suggestive of acute strokes. So I think correlate the clinical presentations with the pathological and neuroimaging pictures.
Any comments, questions? Dr. Praveena Shah has joined. Ma'am, welcome. And if you got any comments, please do make them. Dr. Praveena Shah. I think she's on mute. Any other comments?
I just want to say it was an absolutely fantastic lecture as always. Cleared up all our cobwebs and it made things very simple. Just one thing, sir, this cerebral amyloid angiopathy, is that also related to hypertension, or is there some other risk factor?
No, this is the genetic one is not related to hypertension. But hypertension must be treated if a patient has cerebral amyloid angiopathy, because it is shown to decrease the number of microbleeds.
Right.
You must treat it.
Sure. So the genetic forms may also occur at a slightly younger age as compared
to... Yes. My patient, which I showed, was 65 years old.
Right.
And he presented to me with epilepsy and slight weakness of the left lower limb.
Right.
Could your criteria for treating hypertension be much stricter in these patients?
Correct.
Very true.
Absolutely right. I think it must be vigorous in cerebral amyloid angiopathy.
Yeah. Sure.
But not bringing it down by American standards to 110 by 70. And I would keep it at 120 by 80.
Absolutely.
Because please, you must remember that the lumens are narrowed. Therefore, the blood requires a little greater pressure to go right to the periphery.
Absolutely.
Dr. Praveena Shah, then Rakesh, and then we go to Azad's presentation.
No, it was a very wonderful lecture, Sarosh.
Thank you.
Very clear concepts.
Ma'am, we are very happy that you joined.
I have only reviewed what the authors have put. I must say that I would request everybody to look up one article in neurology from which I took that pathological picture. It's in Neurology 2019, volume 92, and pages 1146 to 56.
So this kind of review tells us how diligently people like Miller Fisher and have worked. What a effort.
Yeah. Rakesh, you want to make any comments? Why is small vessel disease different?
So that is very difficult to, but once the same thing, we are blessed to have good MRIs and DSAs, I would say. What Miller Fisher showed so many decades back, now we can see those on our DSAs after so many years.
Many decades back with a lot of effort.
Yes, we are blessed.
Cutting 400 slices and then analyzing 400 slices, which you all do in about half an hour.
So 5 minutes now. So that's what we are blessed, sir. Really blessed.
I know. I agree. But the MRI has changed the whole concept of
Yes.
cerebral small vessel disease.
Yes, sir. So
And the only place where you can see the microaneurysms, you can literally see them, is in the fundus when hypertension with Charcot-Bouchard's aneurysms. So please.
Quite a few people must have died.
Miller-Fisher?
Quite a few patients of Miller-Fisher must have died. I mean,
No, but they didn't die of the lacunar infarcts. Huh? They died of other causes, and he got the bloody thing. No, don't blame the don't blame the old.
sir, maybe they were also blessed because autopsy was a norm.
I know.
Now it is so difficult to get all these
At
things.
General Hospital, autopsies were a norm.
Yes.
You know, when I think when about Miller-Fisher, the program that Chandrasekhar does, Miller-Fisher was discussed. He left Canada because there was nothing happening in medicine in Canada at that time. Quite unbelievable. I mean, it's not so far back.
Well, I can tell you, he was together with Raymond Adams. And Raymond Adams became a neurologist. I mean, he was a neurologist. And I think the Kiwi person, Denny Brown.
Denny Brown.
Denny Brown was at the Metro Hospital in Boston. And he used to tear up Raymond Adams in the clinical rounds. So Raymond Adams got fed up. So he went back into the pathology room, autopsy room, and dissected out 100 brains and studied 100 brains. And therefore became a clinician with a neuropathological background. And then he started taking Denny Brown to task. But I think from that conflict between two massive giants, I think emerged a lot of knowledge for neurologists.
Yeah. I think for modern times, it will have to be genetics, not pathology. Clinician, geneticist combination.
Immunologist.
Immunologist, yeah, correct.
Once Dr. Wadia told me, yes, he went to a conference on cerebellar ataxias. And he told me, I was nicely suited and I gave my talk on SCA2. Then following me came a guy with his long hair, which he had tied up at the back. He had those round Gandhi glasses, beard, wore jeans and a little coat on the top. And he started talking about genetics and I just could not understand anything. And he dissected the whole spectrum of cerebellar ataxias into the genetics of these repeat disorders. So that is going to be the changing trends. I think we have to accept.
I think even that will change, sir. I think genetics also may not be the end point because we have no idea what brings about the mutations. I think the end point goes to energy of some kind.
Proteomics.
You're coming into your philosophical mood.
No, sir. Just now, genetics and genetics and medicine is correlative science. It's not necessarily causative science. Yeah. Rakesh, any comments? Yeah. Before we go on.
When you read about next generation sequencing, the amount of data that it generates.
Unbelievable.
Amongst that, there's a lot of trash.
Oh, yes.
It takes a lot
to
separate the seed from the chaff.
Absolutely. Absolutely. And they're just scratching the surface. I think there is a lot more there to be understood. And then to be understood. Yeah.
So as all of you always say, things are published earlier than they are proven. So whatever comes up, it is just like a CA case and steroid, what you showed. Amyloid angiopathy, rapid dementia, how steroid is working. Only few cases are there. And
See,
And major journals are publishing that immunomodulation is helping. From pathology point of view, it should not work. It's a bleed, small bleed with inflammation. But it is published now, so we have to give. So don't know, sir, actually the...
See, I saw that one patient in the year 2008. In all my 40 to 50 years of clinical practice, one case.
Yes, sir.
Going to be a rarity.
So the study also says 1 or 2 case reports, and it is reported in NEJM saying it should be treated with steroid without any, I don't know whether it was a natural recovery steroid. It's very difficult to prove, but we are publishing.
Yeah. Yeah.
Okay.
Yeah. Let's move on. I think we're going a little slower. So if we can sort of make up the time in the coming 4 lectures. So next is Azad, who's going to do cryptogenic stroke. Azad puts in a lot of efforts in continuums, and he's going to do it himself. Azad.
Good morning, everyone. Yes, hi. Good morning, everyone.
Good
today we will be discussing cryptogenic strokes, and this is one more part of stroke medicine or stroke neurology, where lots of updates are happening almost every month. So we'll go through the basics of cryptogenic stroke and ESIS. And in the second half, we will take up what are the new developments that have occurred in the last 2 or 3 years, which are still in process. So let's get into it. So strokes, ischemic strokes can be cardioembolic, can be due to a large artery embolism or a lacunar stroke. If it is none of these and we don't have a cause, we call it a cryptogenic stroke. By definition, cryptogenic stroke is a stroke which does not have any of the known 3 causes on standard workup. We will see what the standard workup is. So for a standard workup, the ECG and the 24-hour Holter should rule out an arrhythmia. A 2D echo, or that is the transthoracic 2D echo, not even a TEE, should be normal. And there should be no vessel abnormality to cause a stroke. And it should not be a lacunar infarct. If this is there, by research purposes, remember the term cryptogenic stroke came up as a research purpose. By that, it is called a cryptogenic stroke. Then whether somebody investigates more or no as research purpose, it will be documented as a cryptogenic stroke. However, a detailed further workup, for example, blood investigations, transesophageal echocardiography, or a prolonged Holter may help us clinically undo the term cryptogenic. So let's see the epidemiology and prognosis. 25 to 40%, that means roughly we can say 1/4 to 1/3 of all strokes are cryptogenic, and a good amount of them will remain cryptogenic even after the further detailed workup. There is no age predilection as such. Young is equal to old. Some strokes of other determined cause may be present, but due to inadequate workup, we may often not pick it up. However, it is known that these extremely rare causes are any which ways extremely rare, maybe 2 to 5%, and hence they may not be a major part of the cryptogenic strokes. So like we said, cryptogenics may still remain cryptogenic, even if we do these rare causes, which we generally have read in our medicine and neurology textbooks. What is the rate of recurrence? Is it different from other strokes? Not really. More or less similar. And they have said it is all, in some studies, they have said it is very similar to the cardioembolic stroke recurrence rate, meaning to say this could also be cardioembolic. In terms of severity, they are less severe than an artery-to-artery stroke, but obviously more severe than a lacunar stroke. Now, what is ESIS? So this term, this was probably the part where I took maximum number of days to understand what is the difference between cryptogenic stroke and ESIS, and it was really tough to find it out. So basically, ESIS is embolic stroke of undetermined source, and it is supposed to be a subcategory of cryptogenic strokes. It is forming the majority of strokes. Now, the term, firstly, the term, how did it come and why did it come? So why did it come? The term came into being because antiplatelets were not good enough. There was a very high recurrence rate. And hence, to try and give them anticoagulation so that we can reduce the rate of recurrence, the term ESIS, embolic, came about. But what did it mean? ESIS basically means that on the MRI, the stroke, the ischemic stroke should look embolic. Let me explain it with the MRI. So if we see on the right, they say an embolic source will be superficial, embolic stroke will be superficial cortical, whereas other strokes, whereas cryptogenic includes ESIS and other strokes. So for example, if there is a stroke in a non-superficial territory, it is not called embolic. However, we know that the deep cortical strokes could be embolic, and sometimes an ESIS, we may never find an embolic stroke. But this is the actual true difference between the term cryptogenic and the term embolic. With that is, the MRI or the imaging should look embolic. It should be superficial cortical. Now let's just look at another couple of MRIs. Now, this is different. This is clearly embolic. Even if we will never find a cause, on workup, still it is very simple to understand that these are strokes in multiple vascular territories. So it obviously has to come from a proximal vascular source, which has to be the heart or the aorta. So doesn't take rocket science to call this embolic. And last, it has been said that even if I said initially that lacunes are not considered cryptogenic. However, some papers mention that if it is a young person in age of less than 50 and has no vascular risk factors, we can still call them cryptogenic even if it is a lacune, because they have no risk factors for a lacune. So this is just a concept. Okay. So in a cryptogenic or an ESIS, the standard workup I described, but generally we will go on and do more workup if finances and if it is a large center. These would be rare things like malignancy screening, hypercoagulable testing. Sometimes if our 7-day halters don't work, we have to put in an implantable loop recorder, which is a small recorder put below the skin, and it picks up the electrical activity and transfers it via wireless. These could be even kept inside for 2.5 to 3 years, like many studies have done. Transechocardiographies have been done, and the further future techniques which might come into being are cardiac MRIs, which we will talk. So now let's look at the causes of an ischemic stroke. So this is our old table from Harrison, which tells us all the different causes of an ischemic stroke, which if we do further workup, we may be able to pick up. But recently, in the last 3 years, some newer risk factors have been added. These are also called the non-traditional or the newer risk factors. These are air pollution, obesity and obstructive sleep apnea, periodontal infections. In general, infections were known to cause strokes, but periodontal hygiene has also been added. And depression and psychosocial stress has been significantly associated with recurrence of strokes, maybe not a primary stroke. Not to mention the recent COVID, Ebola, and other SARS viruses, due to their hypercoagulability, have made infection not so uncommon. So now, if in a tertiary center, we actually end up seeing in detail and investigating in detail, by the time we generally call it cryptogenic, we would have done a TEE to rule out PFOs, any atrial septal defect, any proximal aortic plaques. We would have done a halter, a prolonged halter, 3 days, 7 days, sometimes even repeat 7 days to an overall of 30 days to pick up occult AFib. We would have done a dedicated vascular imaging, which can be a T1 FATSAT image for dissection, or sometimes a DSA if we have any suspicion of intracranial vasculitis. A thrombophilic workup will be done. Like we all know, it is only homocysteine and APLA which cause arterial strokes. But if we have a patient who has a stroke with a PFO, then we have to do the entire workup, because then even the venous thrombophilic conditions come into picture. A sleep study is becoming increasingly common, especially in young strokes who are obese or have a poor Mallampatti score and have a history suggesting of excessive daytime sleepiness. Rare other studies include connective tissue diseases, malignancies, metabolic syndromes in pediatrics. And last but not the least, the first thing, generally when all this fails, we sometimes decide to again take a detailed history and realize that the patient probably has consumed some illicit substances, and we've been calling it cryptogenic all along. So once all this is done, then we generally say, okay, now this is truly cryptogenic. Let's just treat it with what currently we are doing. So most would agree that despite the detailed workup, a majority of our cryptogenic strokes continue to remain cryptogenic. So now comes the question of our remaining talk. What does this mean? Does this mean that we are not investigating enough? Does this mean that our investigations are not good enough? Or does this mean that there are some unknown mechanisms which we still don't know? And that is going to be the essence of today's talk. So let's start. What could these mechanisms be which are presently being investigated, and some are coming up strongly? Firstly, embolism from cardiac sources. So we will discuss occult atrial fibrillations. We will discuss all the atrial septal abnormalities. We will discuss this new term called atrial cardiopathies. Then we will discuss the significance of cardiomyopathies. Then we will discuss which aortic plaques are significant. And lastly, we'll go through pulmonary shunt, substenotic, atherosclerotic vascular diseases, and just other causes. Let us start with cardiac arrhythmias. So it is known that atrial fibrillation is a cause of stroke. What has recently been known that any atrial arrhythmia, even something like just an atrial tachyarrhythmia run of more than 2 minutes on a 24-hour Holter or a PSVT, also are significantly associated with strokes in the future. So the question for all of these will come that by doing the detailed investigation, 7-day, 30-day Holters, are we going to detect more AFib, or is the 24-hour Holter enough? Are the arrhythmias causally associated with ischemic stroke? And if yes, are we actually finally going to change the outcome by changing the therapy? So multiple studies in the last 2 decades showed that just an ECG will pick up a very small quantity of arrhythmias, which will be almost doubled if we do a 24-hour Holter, and which will further be increased if we do 7-day, 30-day recordings, or sometimes even prolonged 2.5 to 3-year recordings, as has been done in some study purposes. So it is clear that by doing prolonged Holters, we will pick up more atrial fibrillation. The Crystal AF study showed that 30% patients at 3 years with the implantable monitors, we picked up a atrial fibrillation run. Now, what is significant? Anything more than 30 seconds is considered significant AFib run. But the numbers, the total time in this was much more than in many hours. And even the Embrace study, which did recordings for up to 30 days, showed that 16% were picked up. So at least 30-day Holters will help us to pick up most patients. This was the assert which also at subclinical atrial tachyarrhythmias. So pretty clear that atrial fibrillation is a cause and we should do prolonged Holters. Now let's come to atrial tachycardia. So in this subset, we realized that even atrial tachycardia was independently associated with an increased risk of ischemic strokes by 2.5. And these strokes remain cryptogenic for other causes despite detailed investigations. So very likely the atrial tachyarrhythmia was a cause. This was another fun study. This was done long back before 2000. So men born in 1914, so around their 68th birthday, that is in 1982, multiple patients, many of them were asked to come and take part in this study. There were 402 total, and Holters, etc. were done for them. After a 14-year follow-up study, they realized a strong significance between those men who had some atrial arrhythmia at their initial Holters and getting a stroke, whereas those who did not have any atrial arrhythmia did not get a stroke. So this study showed that if we pick up the arrhythmias earlier, they are definitely predictive of strokes in the future. So we have a therapeutic window. So despite all this, at the end of it, in terms of atrial arrhythmias, 2 questions remain unanswered. What exactly is the significant load? Right now, 30 seconds is reported as significant, but is that significant for a stroke? We don't know. And last but not the least, for these small atrial fibrillations, is anticoagulation going to change the outcome, or does there need to be a larger load of atrial fibrillation or other atrial arrhythmias? So that was about the arrhythmias. Now let's go to the PFOs and other atrial septal abnormalities. Again, the same question. If we detect in more detail, that is if we do TEE for every cryptogenic stroke, if we do cardiac MRIs for every cryptogenic stroke, will we detect more PFOs? If we do that, are these PFOs actually the cause of ischemic strokes? And if yes, is treatment going to actually change the outcome? So only then is it worth all this time. So again, let's start with the older studies. back in 2000, 2002, clear evidence was seen that the prevalence was PFO was significantly greater amongst patients with cryptogenic strokes than amongst patients with already established causes of strokes. Any interatrial septal abnormality, whether it is a PFO or an atrial septal aneurysm or both, significant risk. In fact, atrial septal aneurysms are more thrombogenic. The thrombus can form in the aneurysm itself and can be a cause of strokes, whereas PFO will probably need a DVT or something else to go through the PFO and cause a stroke. Yes, this again, atrial septal aneurysm significance. So now comes the question, if it is atrial, if we are suspecting a PFO as a cause, how do we investigate further? The transthoracic echo versus the esophageal echo versus transcranial carotid Doppler. So which is the best? So 3 studies have been done. This is just one of them, which clearly shows that esophageal echo is the strongest when especially done with the bubble study compared to transcranial Dopplers, again, which is second best, and transthoracic 2D echocardiography is third best. Again, if the transthoracic echocardiography is done with a bubble study, it is much, much better than a transthoracic 2D echo study done without a air bubble. So just simple. So when the doctor's doing the 2D echo, another person or a nurse via a large bore cannula in the cubital fossa will have 2 syringes, one empty syringe with air and one empty syringe with 10 ml saline. And first the cork screw will be shut and they just keep quickly mixing from one syringe to another, which forms bubbles, and then they start injecting. So during the echo, if bubbles are seen to go from right to left, it means there is some connection, which is most commonly an atrial septal abnormality or a PFO. However, we must remember that sometimes just pulmonary shunts, which we will also speak about, can give us the same picture. Also, if the patient does a Valsalva maneuver during this bubble injection, it further improves the outcome of picking up the right to left shunt. So basically, transechocardial TEE with a bubble better than TCD, better than TTE with bubble, and plain TTE is last best. Now, now comes treatment, what we discussed. Is treatment actually going to change the outcome? So multiple studies clearly proved that closure of the PFO or the atrial septum did reduce the risk of recurrence of strokes in the populations who were treated compared to populations who had PFOs which were untreated. I would just like to make one important sentence, which I think I should have made earlier. 25% of normal population has PFOs. 25 of the entire world has PFOs. Whether they are significant or no, we don't know, but 25% have PFOs. So that's why every time we decide to treat a PFO, presence of a PFO means nothing. There is much more which is needed. So anyways, let's come back to the treatment. So all these studies clearly showed that treatment will reduce the recurrence of strokes. This means the causality was proven. However, the risk-benefit ratios are not good, as we will see next. Yes, so 24.2% of normal populations have PFOs. The debate remains antithrombotics are better or anticoagulations are better. Currently, antithrombotic is the treatment of choice. First 3 weeks dual, next single. Unless, of course, we have found a cause of DVT or something else along and we need to give anticoagulation. Next comes anticoagulation or PFO device closure. So in the best of hands, with the best of devices, in the best centers, success has been proven. That is, the benefit of closure is better than the risk. However, this is the current advisory which has come out for treating PFOs less than 1 year ago. Just we'll first look at the green line. So the peri-procedural complication risk is 3.9 plus an additional 0.33 of atrial fibrillation per year. Now this overall risk is much more than the benefit of, look at the line above, 3.4% of prevention of strokes. So even now, even though we know that PFO closure
Azad, your voice has gone.
the peri-procedural risks are very small, and hence people are doing it more often in good centers. So to decide whether whether a patient should be treated, there should be a clear-cut evidence that the PFO is etiologic for the stroke. That means there should be a DVT or something on the thrombophilia workup. It should be a large PFO. It could have an associated atrial septal aneurysm, and there should be documented right to left shunt. So the major advisory has come out in 4 points. Point number 1, in patients being considered for PFO closure, we should ensure that we have ruled out all alternative causes. Number 2, without that, we should not routinely recommend PFO closure. Number 3, we should counsel the patients that 1 in 4 normal individuals do have PFOs. In this particular patient, we will attempt PFO closure only because we have found other risk factors. And last but not the least, however, there is a high chance of the risks outweighing the benefits if something goes wrong during the procedure. So only after all these points are discussed can we go ahead with PFO closure with good devices. This is the same thing enlarged. So this was about PFO and atrial septal abnormalities, which remains a proven cause of cryptogenic stroke, but whether to treat it and how to treat it still remains a question mark, and lots of studies are going on. Now let's come to the third and the most recent development of this new term called atrial cardiopathies. This is a little long. So what is atrial cardiopathies? Any structural or functional change in the atria can lead to thrombus formation in the atria, which can lead to an embolus. What are the markers of left atrial cardiopathy? Means how do we come to know about this new terminology? Number 1, there can be left atrial enlargement. Number 2, there will be atrial fibrosis only. Number 3, markers in the blood like pro-BNP and sometimes even troponin I will be elevated. Number 4, this is an ECG marker called increased P wave terminal force velocity in lead 1. And last obviously is direct AFib episodes. So we will discuss all these first 4, 1, 2, 3, and 4, how to detect them and how to prove that this is an atrial cardiopathy, even though our normal transthoracic echocardio and sometimes even transesophageal echo shows everything is normal. How will we pick up this subtle atrial cardiopathy? So atrial cardiopathies are very subtle deficits which have come into picture. So any abnormality in the heart can actually lead to a stroke. But what is atrial cardiopathy? Any systemic insult. So the same lifestyle changes, the same systemic inflammatory markers like old age, obesity, diabetes, hypertension, sleep apnea, etc. lead to degeneration and apoptosis of the left atria at the maximum. Left atrial appendage and left atria affected the most, leading to remodeling and fibrosis, which occurs in any other organ. This could lead to left atrial dilation, which we all know is an independent risk factor for stroke. This could all lead to electrical abnormalities and arrhythmias, and this could all lead to atrial dysfunction of other kinds. Finally, all of them leading to stasis, thrombosis, and stroke, which is the Virchow's triad. So now let's go through this. Multiple studies are now showing that atrial cardiopathies are significantly associated with stroke. These are just 1, 2, 3, 4, 5, 6, which I have put up here. But there are a lot of them. Basically, they are either studies done after somebody got a stroke and we did detailed investigations with transthoracic echo or cardiac MRIs and saw that yes, the left atrial has been subtly fibrosed. And this percentage was significant in strokes, in cryptogenic stroke patients versus non-cryptogenic stroke patients versus normal population, clearly showing a causality. And then there were prospective or trials which were done on a fresh stroke patient. So a fresh stroke patient underwent the biomarkers, underwent studies, etc. And again, the same relationships were established. However, of course, the question of the treatment remains a problem. Will treatment change? Will our treatment change to anticoagulation even if we find some subtle fibrosis in the left atrial appendage, etc.? So those are being answered. So now I will discuss the markers. How will we as clinicians investigate that, yes, this person has an atrial cardiopathy? So there will be ECG measures, there will be echocardiographic measures, there will be measures on the blood, serum, and there will be MRI measures. Let us first start with echocardiography. So left atrial enlargement of any sort should make us aware that this could be a atrial cardiopathy. Next, there is a term called spontaneous echocardiographic contrast. So normally while doing an echocardiography, we see clear blood flow, but if some sort of a smoke comes up, that's what they call it. The smoke basically means that the blood flow is already slow and is a part of the Virchow's triad. And this again tells us that no, even if the left atrial is normal in size, there is still stasis going on inside. So this is another echocardiographic marker to raise our antennas. And last is the appendage size and the appendage flow velocity on echocardiography. This I just put in for fun, but so they have divided the left atrial appendage shapes into cactus, chicken wing, windsock, and cauliflower types. And they said that the chicken wing is the nicest because even if it is large, but if it is chicken wing shape, there will be no strokes. But this is just one study. Okay, now the ECG markers. So like I initially said, any arrhythmia is now considered significant if for a good duration of more than 30 seconds. And for rarer ones, more than 2 minutes. This could be PSVT, this could be atrial tachyarrhythmias, this could be anything. It need not be AFib. The next is increased P wave terminal force velocity. This is becoming more and more papers are being written on this term. Sorry. Yeah, this is increased P wave terminal force velocity. So on the downslope of the P wave, if present, which is very small, we are supposed to multiply the amplitude into the duration, and that gives us a value. If this value is more than 500, it is a marker of left atrial abnormality, also called atrial cardiopathy. And the other markers are any other arrhythmia. Bayes syndrome has been significantly associated with ischemic strokes. So Bayes syndrome is interatrial block, and it basically means a bifid P wave. Now we know bifid P wave means left atrial enlargement. We used to study in ECG. Tall P wave is right atrial abnormality, bifid is left atrial. So basically it means that. These are, this is a set of all the ECG markers which are coming into importance. There is increased P wave dispersion, P wave duration, increased PR interval. Again, basically means any arrhythmia. And third from the last is the increased P wave terminal force velocity, which suggests atrial remodeling. So this is the ECG markers. We did echocardiographic markers, now ECG markers. Then we come to cardiac magnetic resonance imaging. This is more and more coming into importance. So atrial fibrosis and delayed gadolinium enhancement. It seems one of the most sensitive ways to pick up atrial fibrosis in the left atrium is do an MRI. Normally, left atrium does take up contrast, but the presence and the persistence of contrast on a delayed scan shows that there is atrial fibrosis, which is a significantly proven marker of future atrial fibrillation and vis-a-vis ischemic strokes. And now let's come to the last thing to prove an atrial cardiopathy is the biomarkers. So NT-proBNP has been significant. NT-proBNP, especially during the acute phase of the stroke, or even during the first 1 week, they say is significantly associated with that stroke turning out to be cryptogenic, and that cryptogenic stroke patient in the future turning out to have a cardiac source detected in the future. Cardiac troponin has not yet been proven, but it is being suggested. That was atrial cardiopathies. Now let's come to cardiomyopathy. So in one of the studies by Fonseca et al. On atrial cardiopathies, they realized that when they were doing MRIs to prove atrial cardiopathies, they realized that 7 patients turned out to have an turned out to have the cardiomyopathies. Most of them were hypertrophic cardiomyopathies, and 6 out of these 7 patients were cryptogenic strokes. So now we are trying to prove whether cardiomyopathies are also causing ischemic strokes. So this would be a ventricular thing. Generally, ventricular arrhythmias and ventricular pathologies, except for an LV thrombus, is not really known to be associated, but this is showing it. So that was about cardiomyopathies. There are 3 papers again in this, small things, but that was the main main paper. That was cardiomyopathies. Now aortic embolism. Again, we know aortic embolism can be a source, but again, we know that aortic plaques are very common. So which are the important ones? So it has been proven that a complex aortic plaque is the one we know of so far as a cause of stroke. Now, this would be defined as an aortic plaque of a thickness more than 4 millimeters, which may or may not be ulcerated, or a aortic plaque less than 4 millimeters, but should be ulcerated. Also, when they did studies on these patients, they realized that 24% of patients, especially with cryptogenic stroke, have retrograde flow during diastole, which is not so much in a normal individual. And maybe that is what is causing strokes and these plaques to rupture even more. Again, a concept being studied further. So, fine. So this was all the cardiac mechanisms. Now, before we go to the last three, just one slide. So finally, if somebody says that, okay, I want to rule out all these 5 causes which we have spoken about, which are right now under study, what one modality can I do? Unfortunately, no. Because if we see even cardiac MRI, which normally somebody would answer and say, yeah, let's do a cardiac MRI and pick up everything, it just does not pick up PFOs. And it's even weak to see the valves. Whereas it's very strong to pick up the atrial cardiopathies, so the ventricular cardiomyopathies. So problem is there is not going to be any one modality. We will probably have to go in the normal order, that is do a transthoracic echo. If it is not, it's called a standard cryptogenic, then we do a TEE. And if it's not there and we have a very strong suspicion based on the ECG or based on maybe the NT-proBNP high, then we may go on and do cardiac MRIs for our cryptogenic stroke population like that. Now let's quickly try and finish the talk in 5 minutes or so. Pulmonary shunts. It has been known that pulmonary shunts can lead to strokes. Also in patients with hereditary hemorrhagic telangiectasis who have pulmonary AVMs, we know that they are at risk of cerebral abscesses. So that shows that this definitely goes from right to left and goes to the brain. But similarly, recently, it has been associated even with cryptogenic strokes where nothing else has been found as a cause. These are some of the studies. Won't go into the details, but there was significant association to the tune of 3 standard deviation differences. That's very significant. But again, in a very selected population of patients with hemorrhagic telangiectasis or something of the sort. This is what I was speaking about, patients getting brain abscesses. So we already know that something can go up from there to the brain. And now let's come to the substenotic atherosclerotic disease. So we know that to prove a stroke, at least 50% stenosis in the ipsilateral vessel should be present. Anything less than 50% is called non-significant and then hence called cryptogenic. But this is now more and more proven that you don't need a large plaque. You don't need a 50% stenotic plaque. All you need is a plaque which is ulcerated or is more than 3 mm in thickness or has an intraplaque hemorrhage on detailed studies or has a fibrous cap which has ruptured. So we can see the fibrous cap around, but we can see at one part it was ruptured. That would mean that there would have been a large turbulence on that one day which could actually rupture a fibrous cap. Or it should have a lipid-rich core or plaque echolucency. These are all called AHA, American Heart Association category 6 plaques. So very, very high risk plaques for instability. So proven. But now how do we detect it? So we detect it with multiple things. So MRI, CT angio are good enough for most, but ultrasound is only good enough to see fibrous caps, to see plaque thickness, and to see the plaque echolucency. Sometimes they are even good to see the hemorrhage inside, the ultrasounds, but most of the times we'll need a MRI or a CT. So this was again a study. It showed that 12 out of 32 patients, they did a study on these cryptogenic strokes, which were purely cryptogenic at the end of everything. Even the cardiac workup was done. They decided to study the vessels in detail. They realized that out of 32, 12, that is 1/3, had a AHA category 6 plaque, ipsilaterally and nothing contralaterally. Another study on 138% patients who had less than 50% stenosis, but they realized 39% of these had an ipsilateral plaque and not contralateral. Another study, 579 patients, again showed significance based on these plaque abnormalities. So we have to look out for these particular plaque abnormalities, even if it is a non-stenotic vessel disease. This is something called dark blood MR angiography versus bright blood. So it seems bright blood can overestimate problems, So it is a more sensitive marker. So if we are suspecting something in the vessel, we should do a bright blood MRI. And if the bright blood picks up something, we just need to be now more specific. So then we do a dark blood MRI. Of course, yeah, so that was about substenotic disease. Of course, dissection should not be missed, especially in young patients. If they've done some power yoga or head massages, or sometimes even just weak, it could be a connective tissue disorder, which means they have weak arterial musculature, and easily they can get cut against some of the osteophytes of the bones or something. So there we have to use the FAT-SAT imaging, T1 FAT-SAT. Lastly, other causes. So like we know, there could be multiple other causes. Infection and thrombophilia is known, and COVID-19 is certainly proving it again. Non-atherosclerotic vasculopathies like RCVS, fibromuscular dysplasia, or vasculitis. Incorrectly selected patients, I think we can go in and do the studies, maybe not in everyone. Hypercoagulable states, malignancy, rarely genetic conditions, and metabolic things in children. However, detection of any of the above conditions would generally alter the diagnostic classification of stroke, and then we can actually remove the term cryptogenic from them. Last 2 or 3 slides. So finally, all these pointers which I said, atrial, pulmonary, vessel, the thing remains, is treatment going to change? So this is the last and most important slide. The Navigate ESIS compared rivaroxaban versus means anticoagulation versus antiplatelets, and said there is no benefit. In fact, there was little harm. The Respect ESIS gave us the same answer. However, when they continued studying the Respect ESIS patients for more than 2 years, which was outside the period, they realized that now there is a significant benefit in the patients who are on anticoagulation versus the patients who are on antiplatelets, showing that it is very likely that some sort of an atrial cardiopathy or cardiac problem or a halter, AFib, was actually the cause, but it was occult and short-lived during the first stroke, and the patient has subsequently developed it. So there is still enough scope to say that anticoagulation in the future might come up as a treatment for the ESUS cases, especially if we do detailed studies. In fact, even a warfarin versus aspirin group study, a sub-analysis showed that those patients who were who had a high NT-proBNP on admission had benefit from warfarin versus aspirin, meaning to say that if we actually get the markers right of atrial abnormalities, of cardiac abnormalities, and we can prove that there is a chance this is cardioembolic, we can change the therapy. So in summary, time will tell us whether markers for ESUS are amenable to anticoagulation and hence can reduce risk of recurrent strokes. In the future, we must undertake more detailed investigations for our stroke studies, especially halters. We must keep the newer non-traditional risk factors in mind, especially the treatable ones like sleep studies. We must keep, and yes, in the future, these biomarkers, ECG markers, cardiac MRI, vessel wall imaging might actually become a part of the detailed workup study for cryptogenic strokes. And it seems an exciting time for ESUS studies. Last but not the least, thank you. Dr. Katrak helped me out with all these new things I probably didn't even know, and he's helped me out with all of them. And thank you to Dr. Lalkaka sir and Dr. Shirsat sir, because they wanted to do this topic, but they allowed me to do it. So thank you so much.
Fantastic. Fantastic, Azad. You covered it so well. And
you,
also you were so optimistic. we do hope.
Thank God that, I didn't do the topic. I would have murdered it. Fantastic.
I'll tell you one thing. I'm glad that I'm out of clinical practice, because I think Azad's talk makes me feel that each neurologist will require a very good cardiologist to interpret the ECGs.
Yeah.
They cannot give us a ECG with STT wave changes of noise. They have to tell us more about the P waves and all that sort of thing,
Yeah. I mean, maybe one or two questions we can discuss, even though time is a little.
Sorry.
Azad, management, what anticoagulation is of choice? What anticoagulation do you prefer?
Right now, it's antiplatelets for ESUS, sir. It's not been proven that anticoagulation will help. if we do these 3T MRIs and all those
No,
other
but
things,
if you
we
find
still don't know.
atrial fibrillation, or if you find even an atrial tachycardia.
Okay. So the newer oral anticoagulants are clearly shown to be non-inferior in treatment terms, but better in terms of reducing side effects. So if it's non-valvular, then we can definitely safely go for newer
Do you
oral
have any
anticoagulants.
choice in your
Can I
practice?
ask him what is non-inferior versus superior?
In terms of benefit, in terms of side effect, in terms
Yes.
of
Yesterday he was there or
primary
not?
endpoint.
I'm just joking because only yesterday we had
It is to know whether you attended
what
the
does
session.
No,
non-inferior.
no, I wasn't there yesterday.
Yeah, so you won't answer actually.
Can I stir the honest a little bit? You know, Rakesh, in the so-called garden variety stroke, where you have risk factors, you got hypertension, you got diabetes, you got an older individual, you got whatever, and you see a stroke, ischemic stroke in some area, and the very common finding is that arterial territory looks okay, but there is atherosclerosis evidence generally in carotids and in this and in that. How satisfied are we about understanding the mechanisms of garden variety strokes to separate cryptogenic from understood strokes? I mean, this is a genuine question in front of me. For a large number of my patients, there is an association with risk, atherosclerotic risk factors, older individual, a stroke, but the instances where that particular artery is narrow or the circulation is affected, directly seen on the MR or CT or whatever, is only in minority. So how happy are we with the general concept of hypothesis of strokes in general? And then we don't have these risk factors, we're likely to say this is cryptogenic.
Sir, whenever risk
just one other comment. Frank Mastaglia was asked once, what is the difference between idiopathic and cryptogenic? And his answer was acceptance. In cryptogenic, we accept that there is something that we don't know.
Yeah.
So it's something like that in standard strokes also. I mean, we're accepting that this atherosclerosis has done it, but we prove it only rarely. So what is your take on that?
Yes, I completely agree, because whenever we have multiple risk factors, we presume that small vessel disease is there, and most of them will have lacunar stroke. That is one of the reasons the definition itself in cryptogenic stroke says that lacunes are out. So maybe, sir, 1/3 seemed to be a very nice answer for everything. So 1/3 of the time, we don't know, in spite of having risk factors, we don't know the mechanism, but we presume it is like a small vessel disease.
So going back to last time's comment about genetics, this is also correlative science. This is not necessarily causative science.
Like one of the study
in standard strokes, it actually worried me that I generally don't find a good mechanism. Even though risk factors I always find them, but I don't find the mechanism of stroke.
Satish,
yes, sir.
You will need to do a complete DSA to answer your question.
Sir, this will lead to each and every stroke patient going to DSA.
That is what I'm saying. And
no,
as
sir, why do you say
put
that?
it, are all these fancy investigations going to help us in the therapy of the patient?
No.
And as Asad put it, we have to look at the patient.
Correct.
You know? So if you have risk factors, you have strokes, whether they correlates or not, you will have to do more detailed investigations before you say it. And therefore, is it really worth the extra mile that we are going in the form of treatment?
Yeah.
So at some stage, I think we have to leave our academics behind And be more practical and start treating the patient.
Correct, sir. So that is what finally happens. We have risk factors, we treat them, and we believe that he'll do better. But truthfully, we don't know what's given him the stroke on that morning.
Have we ever done a prospective study?
I don't know.
Never done a prospective study.
One thing is definite.
Ever
When
do?
you treat the risk factors, patients do better.
How do you
Patients
know?
who disobey
How do you
control of
know?
sugar, blood pressure, do badly.
Ashok, how do you know?
If they do better, they are lost to follow up.
No. I think the second last talk is going to show that.
Ashok, in the modern times, will there be anyone who is not taking treatment of diabetes, hypertension, and the likes when detected? So there is no control group.
I have indisciplined patients. You have them, I have them. Indisciplined for people we
But
have.
do we know that they do badly? I mean, there is a lot here that we assume. That's the only point I'm making. I mean, we really do not have a proof for everything.
Chalo.
Yeah, next one.
Let us move on.
Parthvi.
Because we are raising more questions than answers.
Yes. Sorry about that. Parthvi, strokes in young. So Parthvi has shown this presentation to me and I have made some changes in it.
Sound.
Parthvi, we can't hear you. You're on mute still.
Okay.
Yeah, good.
So, ischemic stroke in young adults, it is synonymous with early onset strokes. The age group in various studies has been taken from less than 50 years to less than 55 years, and the definition is very relative. It's different from childhood strokes, which is less than 15 years of age. The young strokes are more difficult because a wide range of potential risk factors and causes exist as compared to the strokes in elderly, which has fixed diabetes, hypertension, obesity, and the likes. Also, the social and vocational situations are harder than older adults because they have an active family life, they are in their reproductive age, they are making influential career moves. And the survival chances are markedly better than old age, but at the same time, there is an increased risk of recurrent strokes. Also, there is an increased risk of other adverse events higher than the strokes in elderly, like neuropsychiatric problems, cognitive problems, pain, post-stroke pain, and seizures. Hence, it necessitates a multidisciplinary approach. The epidemiology, as we've seen in 3 main Indian studies I could find, mainly young strokes are seen in 10 to 15% of all strokes, and they were the definition was taken as less than 40 years of age. Men more than females. Unless it is less than 30 years, then women are more than males. A study from South India was taken in where women were majorly studied, and they were found that strokes in female are mostly seen related to pregnancy and puerperium, and mostly rather than arterial strokes, they were 95% of which were venous sinus thrombosis. One study from AIMS was done in 2014. That is the latest study that is done regarding epidemiology in young strokes, where they took 2,600 patients, and in that 16% strokes were in the age range of 18 to 45 years. And in them, there was a stark majority for males. Young strokes are also affected by ethnicity, genetic factors, socioeconomic and climatic factors. Now about the risk factors in young strokes, most common was tobacco smoking. Thereafter, dyslipidemias, obesity, diabetes mellitus, and cardiovascular disease. The less talked about, but still potentially modifiable reasons which have now come up are migraine and sleep of less than 6 hours. And in migraine specifically, females had more prevalence as compared to males, whereas in all other causes of young stroke, males were predominant. Then we'll talk about some risk factors which are not discussed in that table. Say pregnancy. The highest risk for pregnancy-associated strokes was found peripartum, that is in the 3rd trimester, and postpartum for 6 weeks. And the mechanisms related to pregnancy-related strokes were hypercoagulable state that pregnancy is, eclampsia, peripartum cardiomyopathy, like we saw in the previous talk, amniotic fluid embolism, and RCVS. Also, contraceptive usage, wherein a higher dose of estrogen and for women taking pills containing more than 50 microgram of estrogen showed a higher risk of strokes in the young. Another common cause in India is infections which have shown some association with strokes, like H. pylori, chlamydia, cytomegalovirus, and HIV. Also, we have seen strokes in tuberculosis, neurocysticercosis, and Chagas disease. The mechanisms were endothelial dysfunction and platelet activation, which leads to premature atherosclerosis. I'll explain the pathophysiology of premature atherosclerosis in the coming slides. Also, the interference with other risk factors, like altering serum lipids towards a more atherogenic profile. For example, if you take ART for HIV, it causes dyslipidemia, and that causes more probability to become atherosclerotic. Then hypercoagulable state, and direct causation was found in reasons like infective endocarditis, meningoencephalitis, and HIV. Respiratory tract infections are the most common type of acute infections associated with ischemic strokes. Like now we are seeing an association with COVID-19. Then PFOs, it's as we just saw, 25% prevalence is there in the normal population, but its association with stroke is not very well established. Like there is a score called risk of paradoxical embolism score. It is a 10-point score, wherein higher the score, there is more chances of it being a paradoxical embolism related to the patent foramen ovale. So this can help you establishing causal probability, but it is not, the studies are not very well established. Also, they've tried closing the PFOs in some studies, that is a closed trial, but they had demonstrated no superiority. And this sometimes it also led to incidences of arrhythmias in those who in whom cardiac manipulation and closure of the PFOs had been done. Then illicit drug abuse, especially with cannabis, opiates, cocaine, amphetamines. The mechanisms were acute hypertensive crisis, vasoconstriction, platelet activation, accelerated atherosclerosis, vasculitis, cardiac arrhythmias, cardiomyopathy, and in intravenous drug users, there was also septicemia and infective endocarditis. Thereafter, cancer has also shown association, especially in CNS tumors, head and neck tumors, and leukemias, wherein the strokes were caused due to the direct effects of the solid tumor, due to the effects of chemotherapy or radiotherapy, or the hypercoagulable state, accelerated atherosclerosis, and then endocarditis, varantic endocarditis, and intravascular disease manifestations like seen in lymphoma. After cancer, even genetics, this is extremely rare in our population. Only 3 genetic causes I'll mention relevant to the Indian population, which is also very rare. Pactophile Eden mutation, prothrombin G2021-0A mutation, and deficiency of protein C, protein S, or antithrombin 3. All these 3 are very rare, and these studies have been done in the European population, but even in the Indian population, very rare associations have been found. Then about premature atherosclerosis. Usually atherosclerosis starts after your 50s, but when it starts in the 2nd and 3rd decade of life, the American Heart Association has considered it as premature atherosclerosis. It is found usually at the sites of arterial shear stress, like large artery bifurcations, and appreciable prevalence of detectable large artery atherosclerosis is found in early onset strokes. Atherosclerosis detectable by USG in this age range represents accelerated atherosclerosis and should prompt a search for and treatment of modifiable risk factors. So which are these modifiable risk factors? Mainly include these chronic inflammatory diseases like systemic lupus erythematosus, rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, gout, ANCA-associated vasculitis, Takayasu's, giant cell arteritis, and inflammatory myopathies. Then shortly, I'll just tell about the types of stroke, that is, which are very possible in the young: large artery strokes, cardioembolic, artery to artery embolic, and as we know, cryptogenic strokes. So cardioembolic strokes, mainly these mechanisms were involved, like cardiac sources of embolism causing embolic showers, or like LV clot or an atrial myxoma. Congenital heart diseases like, again, myxomas, fibroelastomas, rhabdomyomas, paragangliomas, and primary cardiac sarcomas. Thereafter, even atrial fibrillation, the most common cause of cardioembolic strokes, and various cardiomyopathies. So after looking at the risk factors and causes of stroke, clinical examination, a full clinical examination and family history is very important to eliminate all these risk factors and or find causality with these risk factors. A complete examination and special attention to the cardiovascular system, skin, mucous membranes, eyes, stature, and deformities, because it will help us find out causes like chronic inflammatory diseases or infective causes. The diagnosis, neuroradiology, we've already discussed, but in the young, special attention to the diagnosis like cervical artery dissection, which is very common in people doing vigorous exercises or in post-yoga. It has been seen in a lot of patients. So if there's such history is found then a suspicion of cervical artery dissection should be made and a CT angio can be done, although the gold standard for dissection is a DSA. Similarly, ECG, and we just saw the various parameters to be seen in ECG in a cryptogenic stroke. Similarly, in young strokes, ECG markers can be found. And then 2D echo, blood tests, urine for illicit drug abuse or overdose can be seen. Then rarely required investigations like transesophageal echocardiography to rule out TFO, and then doing the bubble study and the Valsalva maneuvers. Then a cardiac MRI or a CT to rule out causes like intracardiac masses, congenital diseases, valvular, or if the patient has contraindications to TE. Then a transcranial Doppler, again to see right to left shunts. It is very much highly specific and sensitive as compared to a non-invasive MRIs or angios. And then chest CT to look out for pulmonary AV fistulas or pulmonary embolism. And ultrasound of lower limbs, since DVT can be a source of paradoxical embolism. One recent finding, this was mentioned in the Continuum, that in young patients with otherwise cryptogenic strokes is the presence of carotid webs, which are seen on CT angiography. And they were defined as intimal variants of fibromuscular dysplasias appearing as shelf-like lesions on the posterior aspect of the carotid bulb. So the exact pathophysiology is not mentioned in other articles also, but their association has been found in a lot of young strokes of carotid webs in young people. Then two other causes, APLA syndrome and Behçet's disease. APLA, again, specific clinical findings of venous and arterial thrombosis, along with the history of having recurrent miscarriages and eclampsia. In a young person, we must work up the patient for APLA syndrome and Behçet's disease, that is oro-oculogenital syndrome. Then there have been two more tables wherein a lot of telltale signs of stroke are young strokes are mentioned, vasculitis and post-radiation vasculopathies and things like that. And I can share the slides with whoever wants it, but these are extremely rare causes of young strokes. Now coming to the management, so weight reduction and physical exercise, there are minimal clinical randomized trials, but then expert opinion, and we also see it in the clinical practice that it helps. Then dietary assessment, measures to reduce sodium intake and adoption of the Mediterranean type of diet. In patients, young patients with migraine, triptans and ergots should be avoided because of their vasoconstrictive effects. And now for migraine management, we have a lot of other options to prevent attacks. And in cases of secondary prevention after stroke due to large artery atherosclerosis or small vessel disease or embolic strokes, we should follow the general guidelines which are existing for the adults, elderly strokes. Only the thing to take care is regarding compliance, discontinuation of antiplatelets and antihypertensives and poor adherence to antihypertensives are associated with a heightened risk of recurrent strokes, other vascular events, and mortality in young. So that's it. Thank you.
So excellent Parthi. One or two comments I'll make, and one is that the definition, I mean, various studies have included various age categories, and therefore the results have changed. So that is something to appreciate in this literature. Some take it as 40, some 45, some 50, 55. So accordingly, their spread has changed. But I think in clinical practice in India, premature atherosclerosis, if we want to call it premature, is still the most common reason for stroke at younger ages. And the same standard risk factors that you will see in older ages will come. Two or three things need a mention. One is rheumatic valvular heart disease. I mean, if you look at the country as a whole, rural India and urban India, then uh, amongst the cardiogenic causes, rheumatic valvular heart disease will still be a substantial proportion of people. And one thing that Parthiv we should have probably included, I forgot to tell you, is hyperhomocystinemia,
Yes.
which I think we need to make a mention of.
Mhm.
The genetic cause is also very common, and the deficiency related is also very common. So I think amongst the young ones, when you find a cause,
Hmm.
premature atherosclerosis, rheumatic valvular heart disease, and hyperhomocystinemia are the three common ones. Having said that, I think causes are found. If these are not there, then you search and then you come up sporadically with X, Y, and Z. So those are the general comments on the topic. Open for discussion. Ashok.
A comment
Ashok.
on the age conundrum.
Yes.
The ICMR has defined young stroke way back far in 1980, 40 years ago, as stroke occurring below the age of 40. There was some controversy, and I know for a fact Dr. P.M. Dalal and Dr. Arjun Das were involved, and it became 45. Today, the world says it is between 50 and 55.
It's
But the
5 years more than where you are.
Yes,
That's old age.
and the most exciting definition is given by Dr. Anish Singhal, who is very keen to make it that if a person is working and earning, and if he gets a stroke, he has got a young stroke. He looks at it purely from the economic basis and how it impacts the family.
Yeah.
It's a very, very fascinating thing, because the young stroke is exciting because young stroke impacts the entire family more than, let's say, a stroke in a 90-year-old person. So the age of onset is very, very interesting.
Absolutely.
But ICMR is still stuck at 45. Please,
I
for
think-
the exam-going students, please remember
Yeah.
that.
I think primarily this must have started, differentiating young from old must have started because atherosclerotic and non-atherosclerotic.
Exactly.
So to say.
Exactly.
Please also take into consideration the life expectancy in that country.
Correct.
Absolutely correct.
You know,
Absolutely correct.
or life expectancy in that particular community. Let me say, amongst Parsis, what is young?
Yeah, I follow.
No, I'm being very serious about it.
I
Correct.
follow.
We have a very
I follow.
longevity, you know. So what is young?
Yeah.
So I think genetic factors also,
Of
other
course.
than all your cadacil and all that sort of
Of
thing,
course.
you know, genetic factors of uh, how do you tolerate your lipids, etc. You know,
Correct.
plays a big
Rakesh.
role.
Yeah.
Plays a big role in all this. And secondly, Satish, I would tell you premature atherosclerosis. There is one more parallel example that it is occurring in the younger is myocardial infarcts.
Yeah.
If you ask the cardiologists, they are seeing myocardial infarcts in a very much younger age group.
Yes. Lifestyle
Right,
diseases.
all that.
Yeah.
And India is the capital of diabetes.
Yeah. I mean, if you see Robin's pathology, the first sentence is atherosclerosis starts in the cradle and ends in the grave.
Yes.
So there's nothing like young and
Yes.
old. It is there. It's just that
Yes.
we accelerate it by what we do.
Yeah.
Yeah.
And of course, there are genetic factors which will modulate that also.
Correct.
So I think, yeah, but I don't quite agree with Anish's definition of young age. Because if you see, doctors in India are working till the age of 75, 80.
Correct. But Anish's argument was that the discussion for young stroke came about is the impact it does on a working person. So if you're working for a longer period of time, then you become a young stroke. That's his argument.
Ashok, tell me, what is the basic reason why young stroke should be separated from the old stroke? Because the original belief is that old is athero and this is non-athero.
Mechanisms will be different.
Yeah,
Yes.
that's true.
Which we know is an overlap.
Correct.
The biggest mechanism is still athero.
I get your point. Yeah.
What would you say of young at heart? For the definition of
You have to look no further than Sir Dr. Saroj Katrak for that.
And Dr. Khan, and Dr. Praveena Shah.
Absolutely.
And Nadir Welch.
Yeah.
So Harsh and Jimmy, medical management of secondary prevention of stroke. And then there's one more, Hiral and Rakesh come back. Yeah.
Yes, sir. Sir, audible and visible?
Yes, very much.
Sir. So, good afternoon to everyone. Today's my talk is regarding medical management for secondary prevention of stroke. The chapter in Continuum, which is the base for this talk, is been written by Dr. Anthony Askin, who is the associate professor in University of California, San Francisco. And when I Googled, a lot of publication and studies of him are related to the vascular pathology only. So first of all, why do we need to prevent secondary stroke? So importance lies in the epidemiology. Few of the factual sentences. Recurrent stroke risk after an episode of TIA or ischemic stroke ranges from around 5 to 20% per year. This wide variation is based on different trials and different cutoff criteria. The cumulative risk of recurrence is around 7% at 1 year, which increases to around 18% in 5 years. Now, the most important practical aspect for us here is that the highest risk of the second episode is within the few first days of the initial event. Hence, secondary stroke prevention practically starts as soon as we see a patient of acute stroke within few hours to days. Approximately 80% of the secondary strokes are preventable with appropriate antiplatelet or anticoagulant therapy. Hence, this is an important topic. So outline of my topic is related to 5 aspects. First is antihypertensive therapy. Second is antithrombotic therapy, which is the most important part from practical aspects, which covers antiplatelet and anticoagulant therapy in detail. The third is lipid lowering agents. Fourth is glycemic control. And fifth, we already discussed briefly non-pharmacological management and various risk factors. So first of all is how to control blood pressure. Now, 3 important questions in practical scenario we face. First is when to start antihypertensive therapies after an episode of acute stroke, which antihypertensive agent to select, and target BP in the initial period as well as for long-term control. So before we go on to this, there is clear-cut evidence that use of antihypertensive therapy is reducing the secondary episodes of stroke. So from meta-analysis of 39,000 patients from 11 trials, they have proved that 19% reduction after stroke. And just to name these 2 trials, which have been mentioned everywhere when they mention about antihypertensive therapy for secondary stroke prevention, PROGRESS trial and PETS trial, around 5,000 to 6,000 patients, and both reported around 28 and 29% reduction in secondary stroke. Hence, a very significant number. Now, what is important that both of these stroke trials have used either ACE inhibitor with or without diuretic as the choice of antihypertensive therapy. So coming to the initial choice of antihypertensive agent, the crux lies in the second sentence only. It should be an individualized approach because it depends on multiple factors: age, other comorbidities, CKD, diabetes, asthma, congestive heart failure. For example, latest American guidelines which have recently been published, AHA 2021 guideline, they say that age more than 55 and associated diabetes, ACE inhibitor or ARB remains the first choice. Age less than 55 and non-diabetic, either thiazide diuretic or calcium channel blocker should be used. Now they clearly mention thiazide have a significant benefit over loop diuretic, hence to use thiazide diuretic as the first choice. And for example, if a patient has asthma, we should avoid beta blocker. So these are general medicine concept regarding selecting the first antihypertensive agent, which is of course not related to the ACE inhibitor or diuretic as per the previous trials. More important than selecting the initial agent is extent of BP control achieved, individual tolerability of an agent for a particular patient, and duration of optimum BP control after the first stroke or TIA. Now coming to one more practical aspect, which is timing of antihypertensive treatment after acute stroke. So this can be divided in large vessel versus small vessel. The basic concept is that acute BP lowering in the initial hours of an acute stroke may increase the infarct size, particularly when we are talking about large vessel occlusion. For example, the upper image, which shows that there is a right-sided MC territory infarct and angio also showing M1, M2 junction occlusion. In this case, if suppose, for example, if the patient has come with a BP of 180 or 190, it is reasonable to keep that amount and not to reduce it to a target of 140, which is for longer duration, because it will convert the penumbra in infarct. There are high chances based on evidence-based trials. Now, when we talk about small vessel stroke, this evidence has not been so much robust. So the class 2A recommendation is there for BP lowering in small vessel occlusion, which states there are some benefit which may be extended to the small vessel occlusion stroke also when we are dealing with acute BP lowering. So the recommendation is what? For stroke, wait for 24 to 72 hours. And if TIA, as the initial period of acute observation is not very high, we may start initiating antihypertensive medicine immediately. Now, there should be some indication when to acutely decrease the blood pressure. For example, if the initial BP when the patient presents is more than 220 by 120, or there is evidence of end organ damage. What we mean by end organ damage is due to high blood pressure, there is rise in create, which is of course more than the baseline, or significant damage to the retina or any other end organ damage, or there is evidence of aortic dissection or eclampsia. These are the clear-cut indication where we should not wait for 24 to 72 hours and we should reduce BP acutely. Another indication we all know, when we are offering IV thrombolysis, BP should be maintained by 180 by 105. This has been a slight change from previously what we known as 185 by 110. Long-term BP control is of course around 140 by 90 to 130 by 80. So this was all about blood pressure management in the more or less acute stroke, but this offers secondary stroke prevention maximal during the initial periods only. Now, coming to the second part of the talk, which is antithrombotic therapy. Mainly, we are going to cover indications for antiplatelet and anticoagulant drugs, which are proven as of now, choice of individual agents, and indication of single versus dual antiplatelets. Aspirin, gold standard. Again, slightly touching that topics of non-inferiority. Most of the other antiplatelet agents have been directly compared with the approved drug, and hence the other antiplatelet agents such as ticagrelor, cilostazol, they have been tried as non-inferiority trials to aspirin. We'll talk in detail about that later. So aspirin is the irreversible COX-1 inhibitor. We have evidence that it reduces around 13% relative risk reduction for secondary stroke on long-term use. At least 162 milligrams should be given within the first 48 hours of stroke to prevent the second event based on landmark IST trial. So what is the practical point for us is we should give 325 milligram of aspirin after ruling out hemorrhage immediately, not as a part of primary or acute stroke prevention, but to prevent the second event because it is likely in the initial hours only, but not during the planned 24 hours of thrombolysis when we are not supposed to use this. Another few factual lines are, though we are covering mainly secondary prophylaxis, aspirin for primary prophylaxis always remains a question. But here they say that the risk always outweigh benefits, and hence it is not yet recommended to use for patients with other atherosclerotic conventional risk factors such as obesity, hypertension, diabetes, who has not yet faced the primary event of stroke. Now, dose for long-term follow-up. So they have tried different doses, mainly from 61 milligram to 350. In our setup, we use either 75, 150 or 350. So if we use more than 325 milligram, risk of bleeding is high. So ideally they say 81, and hence for our setup, 75 milligram is enough for long-term management. And now one more topic, if there is a second stroke on aspirin. So this is a very vast topic and much debate plus trials are going on around this topic. So a few of them say that when aspirin is given and patient faces another episode of stroke, half of them may have aspirin, or suppose clopidogrel was given, clopidogrel resistance. But we have to rule out the issues of compliance, drug interaction, and few more others. I'll take briefly this topic of resistance later. So this was the gold standard first line treatment of choice in antiplatelet, which was aspirin.
Harsh,
Now we have...
Harsh,
Yes, sir.
may I
Yes, sir.
just interrupt you for a minute?
Yes, sir.
What is the relative risk reduction for aspirin? To prevent
13%, sir.
huh?
Around 13%, sir.
13, 1-3.
1-3, yes, sir.
That's extremely low.
Thinking that it is about 24, 23 or 24%.
Or 25, I thought,
Hmm.
basically.
Yeah.
But if you say 25%, suppose we say 25% relative risk reduction, that means
Yes.
about 75% can still have a stroke.
Yes, sir.
So does that mean that there is a aspirin resistance?
Sir, exactly speaking, no. So they have usually studied this topic, and they say that, sir, there are a different, as we all know, a lot of mechanisms are going on, which is not related only to platelet aggregation. So, for example, if a patient is suffering the second episode due to some other mechanism rather than mainly atherosclerosis and platelet aggregation, aspirin is obviously not going to work for prevention of secondary stroke. When we talk about atherosclerotic mechanism also, then also platelet aggregation occurs via abundant different pathways, and aspirin prevents only COX-1 inhibition, with some of them having.
Harsh, what I'm talking about is
Yes,
that
sir.
the relative risk reduction of these anti-platelet drugs
Yes,
is
sir.
at best between 25 to 35%.
Yes, sir.
Which is in my opinion not a very good.
Huge amount.
But
Yes, sir.
it is the only practical thing that we have at present.
We have to offer. Agreed, sir.
Yeah, exactly. I mean, it is grossly suboptimal. Yeah.
Yes, sir.
And which is
Yes, sir.
something that none of the doctors explain to the patients when you're giving it. So the patients go away with the impression that it is a short pill.
Yeah.
And they'll come back to you and say, Doctor, how did I get it when I was very compliant on my aspirin?
Yeah, that's
Correct.
Exactly,
Correct.
sir. Yes.
So
Plus,
I
we
think
offer
it's
lifelong
good to
therapy.
explain what is the relative risk reduction with aspirin
Yes, sir.
or
I
with
search
any
few more.
drug for that matter.
Yes, sir.
Yeah.
So going ahead. Yes, sir. So the second agent is clopidogrel. A different mechanism inhibits ADP receptor involved in platelet activation. Now, few important facts about clopidogrel is that though we usually don't practice giving acute loading dose of clopidogrel because we still prefer ecosprin in the initial period, loading dose of 300 milligram should be given when we are preferring this agent over antiplatelet. Mechanism is to reach therapeutic levels within hours for acute stroke, and hence preventing the second episode, which has again highest risk during the initial period. But when we talk about maintenance dose, it is again very low, around 75 milligram. Now, all literature have mentioned that there are no head-to-head trials that directly compare the efficacy and safety together for clopidogrel versus aspirin monotherapy in acute phase for secondary stroke prevention. Why to stress on monotherapy? Because there are abundant trial of single versus dual antiplatelet. And why to stress on acute phase? Because there are significant trial of long-term management for secondary stroke prevention, which are head-to-head for aspirin versus clopidogrel. When we talk about aspirin, as we talk that if breakthrough stroke they have labeled, so if a patient suffers a second episode of stroke on aspirin, do we have trials that prove that clopidogrel is better than aspirin? Guidelines still don't recommend this, but still they always quote this one trial of 2014 published in BMJ, which had shown that clopidogrel reduces the chances of recurrent stroke compared to aspirin, with the number needed to treat around 9. Now, when we talk about clopidogrel versus aspirin after recent stroke, there has been a meta-analysis in 2019. Again, I would like to stress that this meta-analysis, the primary outcome of was combined. So means any event of myocardial infarction, stroke, or peripheral vascular disease, or even unknown cause of death. They included everything. When it was subcategorized, then it was found that significant reduction of recurrence was found in clopidogrel group over aspirin, hence may be of benefit when there is chances of stroke on aspirin. And one more, this has been a clear-cut study, and most of the studies of cardiology do prefer clopidogrel in PCI or stenting. And suppose, for example, we face a situation and in which a patient comes to us with a stroke, and he already has, or in future he may have an episode of myocardial infarction undergoing stenting. And then if we don't want to give dual antiplatelet therapy, clopidogrel should be preferred over aspirin as a single antiplatelet agent for long-term prevention of secondary stroke based on a number of cardiology trials. Now, there has been a long-term comparison for monotherapy versus aspirin and clopidogrel, direct comparison, CAPRI trial, which states that around 20,000 patients were taken, aspirin 325 milligram daily versus clopidogrel 75 milligram daily was the dose used, and risk reduction found after 1 to 3 years follow-up was in slight favor of clopidogrel, again absolute reduction of only 0.5%, and hence still not been able to label clopidogrel as the single antiplatelet agent of choice over aspirin. So proving non-inferiority has been there, but superior to aspirin is still questionable. Now going to single versus dual antiplatelet. So clear-cut guidelines have been recommending only 3 points for using dual antiplatelet therapy. These are based on AHA guidelines recent 2021 as well as this Continuum chapter. So we always use for minor stroke. Now what to define as minor stroke, they have said as NIHSS less than equal to 3. And for TIA, ABCD2 score of more than 4. So high risk TIA or minor stroke, we should use dual antiplatelet for 3 weeks. Second is after carotid artery stenting, we are using dual antiplatelet for 3 to 6 months. And for symptomatic intracranial stenosis, I'll come to this again, around 3 months of dual antiplatelets are better than single. All these are based on chance and point trial for this minor stroke versus TIA. And now not using dual antiplatelet for long term is mainly based on this MATCH trial, which showed increased risk of bleeding with non-significant difference in stroke reduction. Hence, it is not useful to continue dual antiplatelet for more than around 3 to 6 months. Now coming to the intracranial stenosis. Whenever we have the proven mechanism of stroke due to intracranial stenosis, there are 2 trials. First is the SEMPRIS trial, which compared aggressive medical management alone, in which they used 325 aspirin with 75 milligram clopidogrel for 90 days, 3 months, versus medical management along with stenting. So intervention versus medical management was the base of the trial. They found reduced recurrence with dual therapy, but more important point was they found higher rate of stroke and death within 30 days with the use of intervention harm. Hence, as of now, we don't use aggressive intervention therapy for intracranial stenosis. One more trial is CARES trial, which is showing that dual therapy is superior to aspirin alone in preventing asymptomatic continuous embolization. This has been based on transcranial Doppler that they did in all their patients with recent symptomatic carotid stenosis. And they found that microembolic signals in transcranial Doppler was taken as a marker for labeling asymptomatic continuous embolization. The trial period was around 3 months, but they continued to follow patient for around 1 to 3 years, and they found benefit of dual therapy. Hence, dual therapy is evidence-based for intracranial stenosis for 3 to 6 months. Now coming to some more agents of antiplatelet, dipyridamole we all know. Extended release dipyridamole 200 milligram with very low dose of aspirin 25 milligram BD versus aspirin monotherapy has been trialed in spirit study, and 3% absolute risk reduction was found by this dual therapy compared to aspirin alone. Again, this is only for long-term reduction, and we are not talking about acute phase of around few days. But again, this BD dosage plus because of their mechanism of action leading to vasodilation, there were a significant incidence of headache and GI intolerance, and issue of compliance remains when we practically use this regime instead of single therapy. Now coming to antiplatelet resistance. So this has been a very wide topic, sir, but just to illustrate, there are still no clear-cut guidelines about when to suspect resistance, when to order a resistance test, and what to do if we are finding a resistance. This is a gray area, mainly in terms of neurological aspect. They have searched a lot in cardiology and they have got some conclusion, but in our guidelines, there is still no specific recommendation regarding resistance. Recurrence of ischemic, what we call as resistance, is clinically recurrence of ischemic event despite optimum dose and compliance. The patient is taking appropriate dosage, he is very much compliant with the medication, and still he is getting one more attack. This may be labeled as antiplatelet resistance. But when we talk about laboratory method, it would be inability to inhibit platelet aggregation. Now, when we talk about aspirin resistance, which is much lower in incidence, what are the tests that we do? Basically, platelet function test to see whether platelets have stopped functioning or not. So very broad is bleeding time, which is very non-specific. Other are thromboxane production assay, light transmission, and impedance aggregometry. Sir, I checked with the hematology guys and some of the clinics. This test has not been routinely done in most of our private labs, SRL, Metropolis. They do not run aspirin resistance tests. But clopidogrel,
Harsh, I think Breach Candy does it. Is that correct,
okay,
Rakesh? Is that correct, Rakesh?
Yes, sir.
No, in one of
Breach Candy does, and now Metropolis is doing clopidogrel genetic studies.
Yeah.
Yes, sir.
That polymorphism genotyping is available now.
Yeah.
Yes,
Yeah,
sir.
but Harsh,
Yes, sir.
I cannot agree with your definition of aspirin resistance.
Yes, sir.
Despite optimum dose and compliance,
No,
no
actually,
relative risk reduction is ever mentioned.
actually, the correct wording will be aspirin failure and looking for
Yes, sir.
resistance.
Yes, sir. Yes, sir. They have defined different terms also. Correct, sir. Aspirin failure also they have defined.
Because anyway, aspirin won't work in everyone, like Dr. Katrak has said. But when it is
Yes.
not working, one of the things you want to check is resistance.
Yes, sir.
So
So
how
it was brought.
not working?
No, in practically, sir.
Problem is
Clinical.
Correct, sir. Correct, sir.
not
Correct.
working.
Absolutely correct, sir. In practical terms, it will mean that if a second stroke comes, we just make sure that it is not a situation of resistance and we can continue the same molecule. Defining aspirin failure is also a huge problem.
I know.
Yes,
Because knowing Indian patients, they will want to change the drug.
Yes.
Yes, sir.
You know.
Yes.
So
So overall, sir, this has been really a great age.
The problem becomes easier for us because the patient will demand some different treatment.
Yeah.
Yes, sir. And clopidogrel resistance has.
I think the same
Yes.
problem is there with clopidogrel.
Absolutely.
Yes, sir.
I cannot understand why they are doing all these resistance things when the thing is not ideal. The relative risk reduction is not ideal.
So ideally, it should be done for everyone to know whether we should be using that agent or no.
Yes.
And that's its only relevance, actually.
Yes.
There was a practical scenario. We did it in one of our patients who was proven cardioembolic case of stroke, was on anticoagulant, plus due to stenting and cardiac issue, he was on single antiplatelet also. So taking low dose anticoagulant with target INR of around 2 to 3 with low dose antiplatelet of around 75 milligram, but clopidogrel, because it was preferred from the stenting and cardiac aspect of the cardiology unit. So we continued there. Even on dual therapy of one single dose of clopidogrel plus anticoagulant, he still developed 2 more episodes of stroke. We repeatedly checked INR. We increased the target INR from 223 to 2.5 to 3.5. One more episode occurred. Even on that maintained INR, then we checked for clopidogrel resistance. It came positive, but it has still been a very short period of follow-up after that. So we don't know whether further recurrence has occurred or not. But we changed the medication also.
Yeah. What
So
Dr.
you were
Katrik.
on a better wicket because you were also on anticoagulant with the
Yes, sir.
appropriate INR.
Yes.
You understand that?
Yes, sir.
I mean, the situation in stroke really is that over a period of time, wrong things will happen to the patient. But we have to do our best to make sure that whatever can be done is done, which we also know won't be foolproof.
Yes, sir.
I only feel that as young practicing neurologists, you all will have to counsel the patient that I'm giving you these antiplatelet drugs. But please
Yes.
don't think that it is a magic pill with 100% result.
Correct.
Absolutely.
That's very important to tell them. Very important.
Because they'll come back and tell you,
Yeah.
Doctor, I've been taking it regularly.
Right, right.
How did I
Yes,
get another stroke?
Absolutely.
And it can become a medico-legal problem also, in my opinion, with some cantankerous patients.
yes, sir.
So please keep on
Okay, Harsh, continue.
mind, and
Yeah.
I'm still not convinced in my own mind whether there is anything like true anti-platelet drug resistance when the relative risk reduction is so low.
Exactly, sir. Yes.
Sir, that is in the whether the drug is working or not in that patient,
Correct.
the resistance profile. If it is supposedly working, then one would use it with the understanding that its ability is only 25%.
Yes.
So, but one thing, if I can just add, I mean, just a practical what I feel, if I have seen, say, 5 patients with a stroke, a recurrent stroke, and I go into the history and ask them pointedly, out of 5, at least 3 of them would have either missed their dose or not taken it properly, or, done something which, may have caused the stroke. There are only probably, so I mean, I don't know about this figure of 25%, but I think if the compliance and the thing is proper, maybe the protection is more than this 25%. It's just a feeling that I have.
But
It's
Jimmy, this
about 25%, Jimmy.
25% figure is consistent in all the literature from various
25,
parts of the world.
Yeah.
Sure.
The only one which is higher is 33% of a combination of dipyrimidol,
yes,
low dose aspirin.
Yes.
Which for some reason never picked up in India.
Yeah, somehow or the other it never picked up.
Yeah.
So if I get a person who has a recurrent stroke on aspirin, then my philosophy was to put them on this dual antiplatelet drug combination.
Yes. Agrinox, no?
Agrinox, Arino is
Arino.
Indian brand. Yeah.
Yeah.
But worldwide, the ecosprin resistance is in the tune of 15 to 40%, and clopidogrel from 5 to 25.
I see.
Means from genetic study and all things taken together. Problem is, all these studies which we do are not well calibrated. So sensitivity and specificity are not known basically. That is one of the reasons we are not using it regularly.
But the sensitivity of giving aspirin is also 25%.
Like say ticagrelol, the newer molecule, it has less than 1% resistance rate. On ticagrelol also, stents are getting thrombosed. So definitely we can never achieve like 95, 97%.
Your problem is relatively simple. A stent getting thrombosed. You know that your antiplatelet drugs are not working. But here when we say we are giving you only a 25% risk reduction, in other words, you're saying 75% you still have a chance of getting another stroke.
Yes.
So if you do get another stroke, is it the drug resistance or the drug not working, or is it the natural history of the stroke? That question in my mind is not answered by all these things.
Yes. So why, sir? One issue is whether the drug is mechanism of action is occurring or not in a given patient. And second is the drug's capability, which we know is inadequate. Unless we test, we will not know the difference.
I mean, if a person gets a recurrent stroke on aspirin, yes, we will test it.
Both possibilities are there. Recurrent strokes will happen because the capability is so little.
No, but the possibility of drug resistance is to what percentage?
Rakesh just now quoted a high percentage, but I don't test it regularly, I must say.
But
same as
at the same time, the chances of getting a second stroke on aspirin is 75%.
Correct, sir.
So I'm really confused on this issue.
No, sir. If we have a patient, say on ecosprin, who had a stroke, and we test whether he is resistant or not. If he is resistant, then I will change the drug to clopidogrel. Say he is not resistant, then I may counsel the patient, okay, this drug is working, we may or may not change depending on the patient's will. But at least we will have an idea whether to continue the drug or not.
Correct.
The patient themselves will tell you to change the drug.
Yes, sir. And second thing, sir, ecosprin and clopidogrel, both the second problem which adds to all these things is the inhibition is dose dependent. So there are studies that when you increase 75 from 75 to 325, it may start working. Same clopidogrel study came, the OD dose versus PD dose. So after any acute event, whether to give, if there is minor resistance, then if we give 75 BD, it may start working. So all these things we'll have to consider before taking one.
On the other hand, Rakesh, if you look at various studies in terms of dosing of aspirin, starting from very small, some 20 or 30 or 41 in Japanese studies, to 1,200 milligram a day in Canadian studies.
Yes.
But the recurrence rates have not changed that much.
Yes. That is the reason it gone down to 81, sir. From 81 to 150 should be the maintenance dose.
Correct.
But when a failure occurs, then whether we should continue 81 or 150, that has not been.
I mean, logic says increase, but evidence is not there.
Not there, yes.
Another thing is, in the Indian scenario, these dual antiplatelet drugs, they went by these trials of stenting. Right, Rakesh?
Yes, sir.
Post-stenting, dual antiplatelet drugs was the standard of care. The cardiologists extrapolated that to acute myocardial infarct. I'm talking of the Indian scenario. Okay?
Yes.
And then the pharma industry extrapolated that to strokes. And you got a plethora of dual antiplatelet drug combinations.
Yes. So even in cardiology, the indication for dual antiplatelet is for 6 months only.
Is for stenting.
Yes, sir.
But clinically, it has been extrapolated to acute MI.
Yes, but we don't follow the guidelines, sir. That's the problem.
That is basically.
No, double antiplatelets are merrily going on for a very long time in Indian patients.
The other thing is, these drugs that come, combination therapy, not 2 but 3, there is atorvastatin, there is aspirin and clopidogrel in one little tablet. I wonder whether really, the bioavailability would be there, or it would just be going off into the stools and urine.
But that is the magic pill which is advocated by the American Heart Association also.
Polypill.
This combination.
Yeah.
Polypill. Yeah.
Polypill. So that was more for compliance, so that compliance will increase.
But would it get absorbed properly, or I would always be worried about that.
Yes, the standard brand. First, they will have to prove all these things. Then only they are approved ideally. But our place, we don't know.
Correct.
Chalo, I think Harsh.
Harsh, can we please speed up now? We have very little time.
Yes.
Huh? Harsh?
Yes.
Just the salient points now.
Okay, sir. So moving on from antiplatelet resistance now to anticoagulant therapy. Proven indication which have been listed in the recent guidelines are this only. So as Azad sir discussed, ESUS can have a multiple other source of embolism from cardiac source, but as of now they are not proven indication for starting anticoagulant. So what are these? Non-valvular AF, left atrial or ventricular thrombus, acute anterior ST elevation MI with apical hypokinesia or akinesia for limited period, mechanical left ventricular assist device, dilated cardiomyopathy with EF of less than 35 to 40%, and rheumatic mitral valve disease or mechanical prosthetic heart valve. These are the proven indication where we should use anticoagulant rather than antiplatelet. Now comparing different anticoagulants, so mainly this slide shows warfarin versus the 3 newer anticoagulants that we are using. So mechanism, these are vitamin K antagonists affecting factor 2, 7, 9, 10. Rivaroxaban and apixaban, these are factor 10A inhibitor, and dabigatran is direct thrombin inhibitor. These are the typical dose that we use. Important thing is that in patients of CKD, renal dose adjustment is not required, and all these are almost contraindicated when there is significant reduction of GFR in patients with chronic kidney disease. Again, one more important point is half-life for warfarin is slightly higher. Hence, we may combine it with heparin for initial period. And onset of action is also very delayed for warfarin as compared to the newer anticoagulants. So, warfarin versus direct comparison of the newer anticoagulants. Mechanism we have already discussed. Important thing for warfarin, we require INR monitoring, and there is a narrow therapeutic range. When we want to acutely reverse the warfarin action, in case of bleeding, prothrombin complex concentrate is preferred over fresh frozen plasma. But in routine scenario, we give FFP only. When we come to the direct anticoagulants, they have similar efficacy as compared to warfarin, but lower intracranial bleed risk. This has been proven in multiple trials. Hence, now shift is going towards direct neural or oral anticoagulants. They have more rapid and predictable action. No monitoring is required, and very fewer drug interactions compared to warfarin. Hence, much of benefit in pharmacokinetic and dynamic related field also. They are contraindicated with significant renal impairment. This is one of the most practical aspect. Now there are antidotes available. Idarucimab, as Azad sir and other colleagues have discussed, this was monoclonal antibody against dabigatran. So when we check for practical issue, dabigatran company is usually contacted, and they may provide idarucimab. This is available in India. Adnexamet alpha, no one has said that they have ever used, so I doubt whether this is available in India.
So like anti-epileptic drugs, we are going to
Yes,
use
sir.
anticoagulants more for their side effect profile rather than their efficacy.
Right.
Efficacy.
Yes.
Yes, sir. Now coming to the atrial fibrillation and cardioembolic stroke. As you all know, atrial fibrillation affects 5% of population more than 65 years of age. So risk increases with increasing age. Risk of stroke we can calculate with the CHARTS-2R score. Overall approximate risk is around 5% per year. Warfarin reduces the stroke by about 2/3, whereas aspirin only 1/5. Hence, proven indication of warfarin superiority over aspirin for AF with stroke. When we come to ESUS, as sir has already said, Navigate ESUS and Respect ESUS trials do not show any benefit in practical aspect of using anticoagulant in terms of preventing further stroke. Hence, as of now, we use only antiplatelet, which is aspirin. This we already know, both scores. Risk of stroke in non-valvular AF, and one more bled, where we calculate the probable risk of hemorrhage when we use warfarin. I'll skip this slide. So, this is a busy slide. Basically, what it says that the mechanism of preventing different secondary strokes is lying on the first mechanism of the primary event. So, for example, the stroke mechanism is carotid stenosis. The trials have suggested role of carotid endarterectomy versus carotid artery stenosis. This is for extracranial. Now, when we come to intracranial, trials show maximum benefit with medical management rather than angioplasty and stenting. Cardioembolic warfarin is preferred. In AF, again, when we talk about antiplatelet versus anticoagulant is preferred. And anticoagulant in warfarin versus newer are slightly more efficacious, as we can see here, but very minor different in terms of efficacy. More benefit is in terms of side effect. And when we talk about lacunar stroke, dual antiplatelet are preferred over single for short-term period of around 3 weeks to 3 months. Third topic is cholesterol lowering therapy. So statins we already know based on Sparkle trial. What it says that high dose statin therapy may be preferable specifically for the initial period when the mechanism is largely atherosclerotic. One more is that they have preferred atorvastatin of 80 mg or rosuvastatin of 20 to 40 mg for initial 6 months to 1 year rather than 40 mg and 10 mg dose respectively. Two more molecules what they have concentrated is ezetimibe. Mechanism of action is inhibiting cholesterol absorption from small intestine and used in statin intolerant patient mainly. And this is one newer molecule, PCSK9 inhibitor, evolocumab and alirocumab. Both are available in India. These are monoclonal antibodies against PCSK9, which is a liver enzyme that inactivates LDL receptor. So these antibodies against this PCSK9 will lead to more receptors available for removing LDL from the blood. These are usually given subcutaneously. Dose is 140 milligram twice a week. But the cost remains an issue for our patients as of now. Cost is around 5,000 to 7,000 per 1 ml, which contains 140 milligram. Produced by Dr. Reddy's. Fourth topic is sugar control. So again, what Khadilkar sir just told.
1 second before you go, just one point.
Yes, sir.
Currently, our Indian patients do not tolerate 80 milligrams of atorvastatin. They complain
Yes.
of a lot of aches and pains.
Okay, sir.
And I've seen one patient with about 40 milligrams of rivastatin.
Yeah.
And
Yes, sir.
PPK came up to 25,000.
Okay.
Yeah.
So I think these
Yes.
are American guidelines.
Hmm.
Please modulate them to the Indian environment.
Yes, sir. Now going to the fourth aspect, which is sugar control. So basic idea is robust, very intensive sugar control is not providing any significant more benefit rather than usual normal glycemic control, which they are highlighting. So HbA1c of target around 7 to 7.5 is still okay, rather than targeting 5.5 or 6 or very stringent control. When we talk about molecules, metformin is of course preferred because most of the patients have other side effect profile which we can target by metformin, such as obesity and high BMI. Another molecule which they have provided importance is pioglitazone, because a lot of patients of stroke who were not overtly diabetic based on definition may still have insulin resistance, and this can be countered by pioglitazone, but the side effects like weight gain, edema and fracture should be accounted for. Last part is non-pharmacological, which we have already discussed, so I will skip this part. Two more slides. A specific scenario have been given in recent guidelines of AHA. PFO we have already discussed in detail. So as Azad sir told, PFO closure when it should be attempted is 18 to 16 years of age, so relatively younger, non-lacunar proven, no other cause after extensive workup, and PFO with high risk anatomy, as still 25% normal people can also have PFO. Another is cyanotic congenital heart disease patient with stroke. We prefer anticoagulant. Left-sided cardiac tumor with stroke, surgical resection may be attempted. All these are class 2A evidence, not class 1. Carotid or vertebral artery dissection, 3 months of aspirin or warfarin can be tried, but not dual. And abnormal thrombophilia profile, this is more of a practical issue, because when we don't find any other cause, we try to search for protein C, protein S, antithrombin 3 deficiency and other resistance pattern. But even if we found, antiplatelet is to be offered, not anticoagulant. One more is Epla syndrome. If a patient of Epla syndrome is coming to us with a stroke, guidelines still say use of aspirin when the full criteria of Epla syndrome are not fulfilled. For example, if a patient comes to us and we go on for the thrombophilia profile workup and only Epla antibody isolated is positive, but he is not fulfilling the full criteria, aspirin remains the choice. Whereas in confirmed Epla syndrome, those of 2 or more recurrent events of arterial or venous obstruction, miscarriage, eclampsia, warfarin is preferred. Now, one more thing which should be highlighted, sir, we usually do homocysteine in most of our patients. We also discuss young stroke with proven risk factor of homocysteine. Now, newer guidelines say that even if we find hyperhomocysteinemia, there is no role of supplementation of folate, B6 or B12. This has been a new update which has changed from 2014 guidelines. Sickle cell disease, we usually prefer chronic blood transfusion to keep the HbS less than 30%, and if it is not feasible, use hydroxyurea as a second line option. The last take home message, dual antiplatelet are preferred for minor stroke or TIA or post carotid stenting or intracranial symptomatic attributable stenosis. Proven cardioembolic event, warfarin versus direct oral anticoagulant. Small vessel disease or lacunar stroke, short-term dual followed by single antiplatelet. Large vessel occlusion, if it is symptomatic extracranial stenosis, we should offer aggressive treatment in terms of carotid endarterectomy or carotid artery stenosis based on vascular and other local factors plus anatomical factors compared to medical management. But when it comes to intracranial stenosis, medical management is better than stenting. And as of now, US or European guidelines do not prefer any single over the other agents, but all three are preferred: aspirin, clopidogrel, or aspirin plus diparacetamol. There is no single agent which has been proven clinically established superior to other. Thank you, sir.
Fantastic, Harsh. Thank you very much. And Jimmy, your comments, please.
Yeah, I think we are running short of time, but I think it was a good presentation. I think notwithstanding, this business about, the holistic approach of cerebrovascular disease, I think, a lot of emphasis is paid to trying to find out the specific stroke mechanism, if we can. Because I think, identifying the stroke subtype does help in general to, maybe optimize treatment and therefore maybe improve outcomes. I mean, whether it is an extracranial, intracranial, large artery atherosclerosis, whether it is, involving the carotid artery or the vertebral artery, whether it is intracranial atherosclerosis, whether it is small vessel disease, whether it is cardioembolism. I think, there are subtle changes or subtle alterations in the treatment. So I think the last which actually Harsh gave me, there is this American Stroke Association and American Heart Journal, the stroke update, on the recent guidelines of 2021. So he has commented on quite a few of them. Just one or two things I thought. One is that the mechanical heart valves, we must not touch the newer oral anticoagulants. Dabigatran has actually been found to be detrimental. It has caused more strokes and more bleeds. So warfarin is very much the treatment of choice. Similarly, as Harsh said, in renal failure, we give warfarin only. We never give the direct oral agents or anticoagulants. And one last thing is that, in patients who can't tolerate oral anticoagulants for more than a few weeks, and there is need for oral anticoagulation due to atrial fibrillation. People have talked about, surgery and, percutaneous closure of the left atrial appendix. I don't know if Rakesh would like to if he has any experience with that.
Yes, sir. If they cannot tolerate anticoagulation,
yes,
and there is a proven left atrial pathology,
yes,
and a clot there, then
yes,
the closure can be tried. It can be both ways, either surgical or endovascular. Both are available, but
right,
it's a last resort when we cannot give medicine.
right, right.
Ashok wants to say something.
I'm not so sure about venous infarct because more and more patients with venous infarcts are going in for DOACs, NOACs, what have you. I don't know, Rakesh, do you normally use warfarin or you straight away go on to NOAC and DOAC?
So we give choice. First choice will be warfarin. If they cannot, they're not compliance or they cannot follow up, then we give choice of NOAC.
So I've had no problems with NOAC so far. I have a fair number of patients on NOAC. No problem. I normally, right now, I'm going in for rivaroxaban, but most people have advised me to go in for apixaban. Do you have any favorites for this?
No, sir. All three are same, sir. And trials are also showing all three are same, sir, depending on our choice. Sir.
Because there's a bit of a problem, because if you ask the cardiologist, they go for apixaban because of the yes, no is absolutely straightforward. Yes, no is above the age of 60, above, the creatinine of 1.5 is the cutoff period, age is cutoff period, age is 80. So the absolute weight is 60. Weight 60, age 80, and creatinine 1.5. There's no confusion about the...
Apixaban intracranial bleed rates are low. That is the reason we feel safe.
That is coming out now. That data is coming out now. Data is coming out.
I think you should give that cardiologist a ECG and ask him about the P wave.
I knew this was coming.
We should have a small degree in cardiology and practice cardiology also, in terms of stroke.
Rakesh.
Yes, so two things just wanted to add. If there is significant intracranial stenosis, like say 80 to 90%, then how long to continue dual antiplatelet becomes very much controversial. We tend to continue for a few months or maybe years if patient is stable and not having any problem. Though the guidelines say 3 months, but it's very difficult to accept that 90% stenosis is there and I'm reducing antiplatelet, and all of us will have few patients where we'll reduce and stroke happens.
Yeah.
And second comment was about that hyperhomocysteine new guideline they have changed. But unfortunately, they have not differentiated between hyperhomocystinemia causes, whether it is genetic or whether it is due to deficiency. So still, if it is because of deficiency, there should be some role of supplement what we are using.
Correct.
So blindly, we should not stop the thing.
And besides, if it is hyperhomocysteine, someone comes with a high homocysteine level, what is the harm in just giving folic acid and B12? I mean, I would not stop it even if the guidelines tell me to stop.
Yeah, one clinical parameter is the deficiency ones. You start replacing them, and very quickly the levels start falling, and they come to okay. And the genetic ones, whatever you do, they don't become normal. So you get a general idea of what you're dealing with.
Yes.
Sir, Rakesh, sir, only one practical question. If a young stroke we are working up and we find hyperhomocysteemia, we stop labeling that as the cause of young stroke, or?
We just mention is we have found whether it is significant or not. Time will tell it.
And also, I would think the level. You know, if you find a level 100 and more, I would pay much more attention than 50 to 100.
Yes.
And 20, 30, I wouldn't worry too much besides mentioning.
Thank you.
Yeah.
Be likely
so actually,
deficiency induced.
Yes.
And the very high ones are genetic.
So, yes. So many people who are vegetarians have slightly higher levels, 25, 30. Yeah, so we are actually a little after 1 now, and there's one more topic remaining. So for everyone, those who have not given the Google forms to Azad, please fill them and give them to Azad. We have a very good attendance today. And what do we do about the last presentation? We go to the zest of the thing, Hiral. Yeah.
Can they complete it in 15
Yes, Hiral.
Please?
Yeah, I'm sure.
Yes, sir.
Hiral,
What we'll do is
we'll
we'll go for summary only.
Yeah.
Yes, sir.
Please. I think we have to apologize to Hirela.
Yes, she's prepared very hard.
Yeah, but we have to apologize to her. Okay.
That's fine, sir. And so it contains again 2 parts: management of unruptured aneurysm and the unruptured arteriovenous malformation. But I'll just rush through this. So it comes under the CNS vascular anomalies, which are non-proliferative, arterial aneurysms, and AV shunting, which includes AVMs. So just to define, aneurysm are the pathological dilatation at major branching arteries, and the arteriovenous malformation are the anomalous connection between the artery and the veins without an intervening capillary bed in between. There is this tangle of abnormally dilated vessel, which is the nidus. Now, first of all, for the management of unruptured aneurysm, we need to answer 3 questions: whether we should screen for incidental aneurysm, then when it is appropriate to treat an unruptured aneurysm, and what is the risk of rupture if not treated, and then if we decide to treat, what should be the modality of treatment, endovascular versus surgery. So the prevalence of unruptured aneurysm varies from 1 to 9% across the population. Average 3% of the population harbors unruptured aneurysm, and 20 to 30% will be having multiple aneurysm, and 20% will be having positive family history. And the prevalence rates from the India are also kind of similar, 0.75 to 10% across the various parts. Regarding the screening, there is a recommendations are that if there is a positive family history, meaning 2 family members having either aneurysm or history of subarachnoid hemorrhage, then we should screen for aneurysm. And either patient is having polycystic kidney disease, then we should screen for aneurysm. The risk factors associated with high prevalence of unruptured aneurysm are female gender, higher age. Japanese, Chinese, and Finnish population have, for some reason, higher rates of unruptured aneurysm as well as aneurysmal subarachnoid hemorrhage. Hypertension, the wall stress, meaning the vascular inflammation and the cholesterol, and importantly, smoking. This has a very large bearing on the prevalence of unruptured aneurysm. And to define the risk of rupture of this unruptured aneurysm, there is a scoring given, which is called phases, which is derived from the study of 8,000 patients. And 6 risk factors have been quoted out, which are the population. Again, the Japanese and Finnish population has higher risk. Hypertension, age as increases, risk is higher. As the size increases, risk is higher. Previous history of SH or the site of aneurysm that we'll see. And according to the risk factor, scoring has been given. The score varies from 0.25% to more than 15% on basis of what all risk factor patient is carrying. Now, the risk factors for ruptured are mainly two: aneurysm related and the patient related. Aneurysm related are the size and morphology of aneurysm, the location of aneurysm, which is the posterior location, and the ecom and pecom aneurysm. These are having higher risk of the rupture. Also, the direction of flow, the symptomatic aneurysm, and if we find aneurysm growth on follow-up imaging, then these are higher risk for rupture. So about the size and location of the rupture, there are many studies done, and all of them have stated that as the size is the strongest risk factor predicting the rupture, and also the location. As we can see here, less than 7 mm, hardly any risk of rupture. As the size increases, 7 to 12, and up to the more than 25, the risk exponentially increases. And also risk is higher here in the posterior circulation and pecom aneurysm compared to the anterior circulation. But as against this, size does reflect the risk of rupture, but it is always not true that larger the aneurysm, greater the rupture risk is not entirely true, because the prevalence of small aneurysm is also as high as 40 to 50%, and they account for substantial amount of aneurysmal subarachnoid hemorrhage. So meaning there are many other biological risk factors playing role for the rupture. And for this, we need to define the size indices, but I won't go into detail of this. This is completely done on the DSA angiography, where we can find the ratio of size, that is the diameter of the dome across diameter of the neck, which is the aspect ratio. As it increases, the risk of rupture increases, and others are flow angle, the size ratio. So even if the aneurysm is small, this size indices reflect the risk of rupture in them. And there was a study on Indian population from South India to define the risk factors for this subarachnoid hemorrhage. And they also found the similar thing, hypertension and smoking were the mainly largely determining factors. This is the same thing. Now, if we directly come to the decision making, whether to treat the patient or just to observe an unruptured aneurysm. So firstly, we have to analyze patient and aneurysm related factors, what we just discussed, and then discuss the suitability of patient for endovascular versus the surgical clipping. So which unruptured aneurysm is to be treated whenever the aneurysm is more than 7 to 10 millimeter of size in a patient with life expectancy of more than 12 years, then it should be treated. Or if it is more than 5 millimeter size, then in young or middle-aged people, it should be taken for treatment. Or either there is a history of previous SAH or symptomatic aneurysm or a growing aneurysm should be candidate for treatment. And when there are small incidental aneurysm, less than 5 millimeter, low risk of rupture, then we should consider treatment only when there is family history positive or other risk factors like smoking and hypertension. Then there is a detailed scoring. Yes. Yes.
When you say symptomatic aneurysm, what do you mean?
So sometimes aneurysm can give headaches because of the size, or if there is pecom aneurysm, then it can compress third nerve, or can give rise to cranial neuropathy. Yes.
Yeah, it doesn't become asymptomatic. Here the topic is asymptomatic aneurysm. So
yes, unruptured aneurysm. So unruptured, but if they cause some of
but symptomatic.
Symptomatic due to its size.
Size,
location.
And secondly, sometimes growing aneurysms. That means you have to observe the aneurysm over a period of time to know that it's growing.
Yes, yes.
So what is the period of time that you will observe the patient?
That I've included the follow-up imaging details.
Okay.
So this is a scoring system to prefer that to know which treatment modality should be preferred over another. This is a unruptured intracranial aneurysm treatment score, which is developed by international group of specialists, and it provides a guide to prefer one modality over other. And it also it includes the aneurysm related factor, which we discussed, the size, morphology, location, the patient related factors, the age, the other risk factor, life expectancy, and the symptoms, and the treatment related factors like aneurysm size related risk or the complex anatomy and etc. So if we decide, based on this score, if we decide to observe the aneurysm, depending on the factors, patient related aneurysm related factors, then we need to have a serial follow-up imaging to look for the aneurysm growth. Now, this growth of aneurysm is very inconstant and episodic. It is not a linear growth. There are periods of growth and there are periods of just silence. So frequency of follow-up is to be decided. But they have said that the risk of rupture in first year after finding aneurysm is very low. But clear-cut how often we should have the follow-up imaging is they have not mentioned. They define the growth as enlargement of more than 1 millimeter in any direction, and this growth indicates basically an unstable aneurysm, and this has 5 times higher risk of rupture rather than the not growing aneurysm. So when we find this unstable aneurysm or growing aneurysm, we should reconsider the decision of conservative management, and obviously the control of risk factors, hypertension and smoking cessation, as they have mentioned that smoking hastens the growth of aneurysm. Here, there are risk factors which predict the growth of aneurysm. The phase score was to predict the rupture of aneurysm, and here the risk factors to predict the growth. But these are almost the same. History of previous subarachnoid hemorrhage, the location of aneurysm, again posterior circulation hemorrhage, posterior circulation aneurysm have higher risk of growth. As age increases, the risk increases for growth. Again, the population and as the size increases, more chances of growing, and the shape also, the irregular shape or multi-lobe shape, they have higher risk of growing. And based on this scoring system, we have to predict the risk of growth at 3 year and 5 year. So based on the risk factors present, this 3 year risk and 5 year risk of growth percentage varies from 5 to 40%, and here from 8 to 60%. Now, surgery versus endovascular treatment. Here, this middle diagram shows the surgical clipping here, and this one is the endovascular coiling. Plus, now advanced techniques are available, which are flow diverter, which can be used when the aneurysm is wide naked or giant aneurysm, or when the underlying artery is dysplastic, then we need to reconstruct it with the flow diverter. But obviously, it carries the risk of giving dual antiplatelets pre and post procedure that we should balance with the benefits. Now, surgical treatment. About the surgical treatment of unruptured aneurysm, 54 studies have been analyzed. The complication rate that have been is 8%, and fatality rate is very low. The risk associated with complication with higher age, male sex, or there is underlying coagulopathy, and obviously the conventional risk factors of smoking, hypertension. Also, the posterior circulation location is unfavorable for surgery. Aneurysm obliteration rates with surgery are very good, around 91%, completely occluded, and the rate of hemorrhage after surgery is very low, 0.38%. We'll compare this with endovascular treatment later. Now, there has been a few trials with directly head-to-head comparison of coiling versus clipping. There are this was a trial with coiling versus clipping in unruptured aneurysm. This was a systematic review of several trials, and this was one randomized control trial of coiling versus clipping. And both of these, the conclusion was same, that overall mortality between the coiling and clipping are same. Clipping has higher short-term disability, less than 6 months. Post-operative patients have higher rates of neurological and cardiac complication and higher disability, but this difference disappears at long term, more than 6 months. So the conclusion is same, no significant difference in permanent morbidity at 1 year. At 1 year, coiling and clipping both do similarly well. So to summarize, endovascular approach has definitely less short-term morbidity and higher chances of re-intervention. So it can be preferred in patients older than 50 years to avoid the post-operative preventive morbidity and complications. And obviously in posterior circulation and surgically inaccessible location, we have to go for endovascular approach. Whereas for clipping, the points are higher short-term morbidity and higher, but at the same time higher durability. Then it should be preferred in a younger patients, but we should consider risk of post-craniotomy epilepsy here. So look at the life expectancy in younger than 50 patients with anterior circulation, surgically accessible, go for clipping. And these were the two landmark trials for the treatment of aneurysm. IZET was for ruptured aneurysm, and this international study of unruptured intracranial aneurysm. These two trials have concluded that whenever the anatomy is favorable, then endovascular approach seems to be the treatment of choice. It has led to 22% overall improvement, increase in overall improvement in outcome. Anterior circulation, MCA is better clipped, and posterior circulation are better coiled. And the AHA recommendation are also in line with this, that patients with unruptured aneurysm who are considered for treatment, first they should be fully informed about the risk and benefit of both the treatment, and coiling is associated with reduction in the procedural morbidity and mortality versus clipping in cases, but overall higher risk of recurrence. So that was about the aneurysm. The next is unruptured AV malformations. The AV malformation prevalence is very low, 1 in 2000 MRI scan, 0.05%. Here we can see the normal capillary network, and here is the abnormal natus formed between the arteries and veins. Now they also, AV malformation also may remain stable. They increase or decrease in size, or either rarely they may spontaneously regress in 2 to 3% of cases because either of the atherosclerotic or thrombotic occlusion or low flow. Now, amongst all the AV malformation, 10 to 20% are incidental, and the rest are symptomatic. Symptomatic, they can lead to seizures, headache, focal neurologic deficits, but sometimes they can lead to progressive neurological deterioration because of the recurrent hemorrhages, mass effect, an important phenomenon of vascular steal, which diverts the flow away from the normal region towards the shunt, and it can lead to neurological deterioration. Important, the most dreaded complication is hemorrhage from rupture of AV malformation, mortality rate of 12 to 60%, and of those who survive, they also carry severe deficits. So we should first determine the risk of hemorrhage of AV malformation, which is which varies from 1 to 3% per year. And again, as for aneurysm, the risk for rupture depends on these factors. Previous hemorrhage from AV malformation, as the age increases, risk increases. For Hispanic ethnicity, have higher risk of rupture. Deep brain location and the deep venous drainage. These two are also having the higher risk of hemorrhage. But the strongest risk factor is the previous history of rupture of brain area. So depending on this factor, we will define the risk of rupture, and then whether to treat with preventive treatment or just to observe, that we have to decide. If we decide to treat, then there are 3 modalities available. One is this microsurgery, second one is the endovascular embolization, and third is the radiosurgery. In microsurgery, I'll just brief this to that they have found excellent outcome with microsurgery for low-grade lesions, grade 1 and 2, and higher grade lesions, grade 3 and grade 4, have higher mortality. Now, what are these grades? These are Spetzler-Martin grading scale, which depends on the size of AVM, the location of AVM, and the venous drainage, superficial or deep. And depending on these grades, the class A, B, and C of AVM are designed. The lower grades, lower class have lower surgical risk. So grade 1 and 2, class A and B, lower surgical risk. Grade 3, 4, class C, higher surgical risk. So avoid surgery in them. And this is an additional scale which adds up age, the bleeding, history of bleeding, and the compactness of AVM to this scale. It adds to the accuracy of prediction. Now, about the endovascular embolization, we use here microcatheters to deliver the embolic material, which are either onyx, which is ethylene vinyl alcohol, or the glue, which is butyryl cyanoacrylate. And then they will, so through the microcatheters, embolic materials are delivered around the feeding arteries or the nidus. And if the aneurysm is large, then we might need stage treatment with multiple embolization session. Now here the complications are mainly related to the thromboembolic complication of catheterization, which can lead to the ischemic stroke or ICH because of the injury to vessels or periprocedural rupture of AV malformation. And the risk factor associated with complication is large AVM size and multiple embolization session. So there was a systematic review in 2019 which reviewed the 600 patients, about 600 patients of AVMs who were treated with embolization. Complete obliteration was found in around 45% of the patient. Complication rate was 24%. But here importantly, 34% patient were Spessler-Martin grade 3, meaning higher grade lesions which have higher surgical risk, and these are still feasible for endovascular embolization. The next is radiosurgery. Radiosurgery which deliver the high energy beams of radiation to the brain AVM needles, which leads to sclerosis and occlusion of the blood vessels. Now here, radiosurgery has mainly two roles. One is the obliteration of AVM, and the next is to preserve or improve the neurological function and to reduce the seizure. And sometimes radiosurgery is done for these two objectives after surgery, to reduce seizures mainly. But here, important limitation is that the effect of radiosurgery is delayed. There is a latency period of 2 to 4 years before complete obliteration. And sometimes we have to use multi-modality treatment. We have to combine endovascular embolization prior to surgery to reduce the bleeding and facilitate complete resection, and to target inaccessible portions of AVM or deep feeders that are difficult to control surgically. Or either embolization can be performed prior to radiosurgery to, again, for same reason, to reduce the needle volume. Embolization also can be done for various objectives, like sometimes it is done only targeted embolization in a large AVM, targeted towards the high-risk angiographic features. And sometimes it can be done only as a palliation in a large AVM when there is a vascular steal. The embolization is delivered to high-flow feeders to divert the flow away from the needles. Now, regarding this preventive treatment versus observation, major trial is Aruba trial, which was a randomized control trial comparing the conservative versus preventive intervention. And they found that the preventive interventional therapy carried statistically significant higher risk of death and symptomatic stroke versus conservative treatment, whereas conservative treatment was associated with lesser functional impairment and lesser rates of death and stroke. So based on this, the recommendation was laid down that unruptured asymptomatic brain AVM should be observed. But then comes the post-Aruba era, which is recently published in December 2020 only. And they have criticized this Aruba trial for various reasons. One, that in Aruba trial, the modalities of treatment used were very heterogeneous. They used disproportionate number of embolization, and microsurgery was preferred in very less numbers. Like this, 68% of surgically favorable grade 1 or 2 AVM were there, but surgery was performed only in 5 patients. So there was discrepancy and deviation from the standard practice. Also, 25% already had hemorrhagic complication, carrying higher risk with interventional therapy. Also, the primary outcome was fluid. They defined the new stroke symptom as either new onset severe headache or new seizure or the ischemic complication. All were high in interventional arm, but they were followed again for a short term, about 3 years. So they estimated only the immediate risk, not the permanent effect of these stroke symptoms. And also, if the radiosurgery is done, then it takes 3 to 5 years minimum to completely obliterate the AVM, and the study was only for 3 years. So for many reasons, this was criticized. And then post-Aruba trials were many published in 2017 and 18, and they collectively said that microsurgery can be labeled as gold standard for managing AVM, especially low grade. And the embolization has role mainly as adjunct to microsurgery. This was the conclusion of post-Aruba trials. So to summarize, management of unruptured AVM, if the grade is low, Spessler-Martin grade 1 or 2, class A, then the microsurgery is preferred definitely here, except when the AVM is diffuse or patient is older. Then we should consider radiosurgery versus embolization. Then next is class B, grade 3 AVM. Then surgery is effective, but here surgery carries some risk. So it is to be done only in young patients. If the patient is older or diffuse AVM, then consider other options. Similarly, for higher grade AVMs, first do no harm because surgery here is very risky. So conservative is preferred, or except when the patient is very young or either they have disabling or poorly controlled seizure, or they experience progressive neurological deterioration, then in this situation comes the role of endovascular embolization, which are not feasible for surgery. Younger patient, disabling seizures, neurological deterioration, then we should consider the endovascular embolization here. Thank you.
Thank you, Hiravi. I think it's a large topic and
Yes.
a lot of material.
And a lot of controversies.
Yeah. So Rakesh, you want to say one or two things before we close?
Yes, sir. The unruptured AVM and aneurysm both are same. Unless patient is symptomatic, we should first think of conservative treatment. Now, if the aneurysm is more than 7 mm, definitely we should consider treatment if it is safe. Which moderator to choose depends on the expertise available. AVM has more controversies because even ruptured AVM treatment trial failed because of the complication associated with the treatment. Having said that, whenever there is easy aneurysm, like grade 1 or 2, like a right side cortical, which is classical grade 1, it is easy for surgery, it is easy for endovascular. At the same time, its morbidity and mortality is also low. So whenever the risk is less, the surgical risk is also less. The moment we go on higher grade, all risk increase. That is where the controversy is there. But if the aneurysm, if the AVM size is small, it should be considered for treatment. Other way around, because large aneurysms, larger the risk. Among site, if it is cortical, again, it is easy to treat and the risk is less. So it should be considered. If in a AVM, there is associated aneurysm, then it should be considered for treatment. Because most of the time, that is the site which bleeds. So if there is a AVM and it has aneurysms in it, a consideration for treatment should be given. Like second thing, whenever there's hemodynamic change, like the AVM is so large that patient is getting ischemic symptoms, again treatment should be offered. And as for all the diseases, individualized treatment depending on the surgeon and the endovascular person and radiosurgery, we should take the call.
And just one question, is natural history well delineated for these?
Yes, sir.
Do we have enough natural history data on this?
Yes, sir. AVM we have. Aneurysm, sir, it's difficult because the moment it crosses.
The moment it is found, somebody will try to do something to it. So how do you know the natural history?
It's very difficult, sir.
Great. Any other questions or comments on this? Ashok. Ashok, you want to make a comment?
About multiple lesions. Very often we've had an experience where we have dying. If we have a subarachnoid hemorrhage, we go ahead and get it operated. Then we do a repeat angio after 3 months, and then we pick up 1 or 2 more. And then there is chaos from the family. Why did you take it out the first time? So sometimes it's not picked up, if you know what I mean. So
that it's a 20% chance the patient may have multiple aneurysms whenever we have aneurysm.
Yeah.
But the rule is that we only treat symptomatic in acute setting.
So that becomes difficult to convince the family at that point. They're so anxious. They've gone through hell.
Yes. And
emotionally and financially. So
great. So I think we had an absolutely fantastic session today. You all will agree with me. I think all the topics are so beautifully covered. And
this is a 3-day conference.
Meaningful
the data is
discussion.
3-day conference. It's a 3-day conference. Yeah. It is amazing.
Yeah. And we've had quite a large viewership today. We had almost close to 175 people watching, which is very good. Much better than earlier when physically we were meeting.
Oh, physically.
So
tough to get up at 7 a.m.
Yeah. So Azad, the next one is which date of June? It's the last Sunday of June. I think it is 27th. So this was 30th. And the topic is systemic diseases. So soon we'll line out the thing and send. So shall we close at that? Any other Dr. Khan, sir, any comments?
I think it was a very, very good session. And thank you very much for all the comments by different people. Excellent. Thank you.
Thank you. So thanks everyone, and we meet last Sunday next month, systemic diseases. Azad, thank you very much for everything.
Bye, Jimmy. Bye, Jimmy.
Bye. See you.
Next,
Thank you.
Azad, next
Thank
time
you.
systemic disease.
Yes.
So just send me the topics and we will.
Index.
Yeah.
Yes, sir.
Yeah. Okay then.
Bye.
See you all.
Thank you.
See you all.
Thank
you.
Thank you, sir. Thank you.